Good morning, everyone, or good afternoon. Thank you for joining our Global Surgery Satellite session. Today, now more than ever, the essential role of surgical obstetric and trauma and anesthesia, or also called SOTA care in advancing global health. This morning, I'm your host. My name is Teresa Chin from the University of California, Irvine. And I want to welcome you here today. This session is a combined effort from multiple organizations and institutions, and I really want to thank you, CUGH, for allowing us to have this session, as well as the organizers and the combined effort in this group. For some housekeeping, if you have any questions or comments, please put them in the Q&A rather than the chat, if possible. That would be great. These are the three sessions that we have today. The first hour, we're going to talk about the background of SOTA and UHC, Universal Health Coverage, current challenges in achieving the SDGs. The second hour, we'll talk about working together towards surgical system strengthening. And the third hour, we'll talk about sustainability for effective SOTA care. For our first session, I want to introduce our moderator, Walter Johnson. Walter Johnson is a neurosurgeon at Loma Linda University. He's a former lead of the WHO program on emergency and essential surgical care. So without further ado, Walt.
Good morning, everyone, and greetings from sunny California. I'd like to thank the organizers of this meeting for the kind invitation and for the opportunity to be here with all of you. I would just like to say in the beginning that WHO has defined UHC, or Universal Health Coverage, as one of the great priorities of the current Director General, Dr. Tedros. And they define UHC as all people and communities receive the quality services they need and are protected from health threats without financial hardship. Dr. Tedros set out what he calls the triple billion goal, wanting to ensure that during his tenure, at least 1 billion more people were covered by universal health coverage. This is not something that every member state on the planet embraces. Some countries are reluctant to have universal health coverage for a variety of reasons. But actually, universal health coverage is the target that underpins and is essential to achieving all of the SDGs, the Sustainable Development Goals. UHC pulls it all together, especially in regards to surgery, obstetrics, trauma, and anesthesia care. The SDGs on reducing maternal mortality, infant and under 5 mortality, reducing the premature deaths from NCDs, and reducing by half the number of road traffic accident deaths can only be achieved by promoting SOTA care. They'll never be achieved without it. This is also the underlying basis, if you remember WHA Resolution 6815 on strengthening emergency and essential surgical care and anesthesia as an essential component of universal health coverage. This is built right into the resolution of what I was mandated to implement in 2015. So this is a key ingredient and cannot be overlooked. UHC and SDGs and the surgical resolution are intricately entwined. Dr. Key Park and I were in Bogota, Colombia last week at a World Federation of Neurosurgical Societies meeting. And 6 years ago, we had what we called the Bogota Declaration on promoting global neurosurgery as a discipline. And it really is the discipline of neurosurgery clinical care with public health and with social justice issues of equity and access to care, equity in care delivery, and it's just taken off. It surprised both of us the degree that it has just taken off, especially by young people. And actually, the next two meetings of WFNS, the next one in Cape Town in 2023, and the following one in Madrid in 2025, are both accepting the theme of global neurosurgery. It is such a emphasis at this time, and I can't imagine that global surgery in the general sense, or global anesthesia, or global obstetrics, or global trauma is any different. We are very privileged today to have a fantastic panel. If the three panelists can turn on your cameras so I can see you. We're very blessed to have, first of all, Dr. Manuel Mukasa, who was, when I was in Geneva, was the health attaché for the Republic of Zambia, and was really the driver of Resolution 6815. He made it across the goal line with that resolution. Dr. Mukasa is an orthopedic surgeon. He is currently an adjunct professor of global surgery and the founding director of the SADC WITS Regional Collaboration Center for Surgical Healthcare in South Africa. Second, we have Dr. Catherine Chu, who is originally from California, and who is the director of the Center for Global Surgery and a professor of global surgery at Stellenbosch University in South Africa. And thirdly, we have Dr. Mark Shrine, who is currently the O'Brien Chair of Global Surgery at the Royal College of Surgeons in Ireland, Dublin, Ireland, and a lecturer at the Harvard Medical School. He is by practice an ENT surgeon, and I'm very proud to count all three of them as very good friends and colleagues. So without further ado, I would like to turn the microphone over to Dr. Manuel Mukasa. Emmanuel.
Thank you so much, Walter, and good morning to all of you, or good afternoon or good evening from where you are. As introduced, I will start off, but mostly to give the background on surgery, obstetrics, trauma, and anesthesia, and universal health coverage. We'll look at a bit on the challenges we are facing and how we are planning to achieve its role, fulfill its role in the SDGs. I hope you're able to see my slides. If you can't, please, somebody let me know. So, as you know, the momentum peaked in 2015, but in the last 2-3 years, we've seen a stagnation a little bit because of changing global priorities, because of the challenges we have faced. All of you, I'm sure you know about the onset of the COVID-19 pandemic, which is still ongoing. Of course, it comes in waves. And throughout the COVID-19 pandemic, we've seen a shift in the focus of what we're working on, both at global, regional, and at country level in terms of public health, including clinical care. For us, speaking as the people who work in the surgical field, really, we've seen a neglect of investments in improving surgical capacity at all levels of the health system, especially at country level. And yet, we have had to maintain and sustain these services throughout the pandemic. There was no time when we had to slow down. Of course, we suspended some parts of our healthcare systems in terms of surgical healthcare delivery, but overall, we really had to sustain these services throughout the COVID-19 pandemic, which just goes to show how important surgical services are to universal health coverage, attainment, and also, of course, the sustainable development goals. I just want to remind all of us, I think you've seen many slides that link how really surgery, obstetric, and anesthesia care supports the attainment of UHC. I just have maybe
Mukasa,
one.
we
Yes,
cannot see your
please.
slides. Can you please show your slides?
Okay, let me just back. I thought I'm showing the slides. Let's see. Are you able to see my slides?
Yes, thank you.
Thanks.
Okay, if you don't mind, I can just go back. I'll go quickly so that you just follow. We can see the slides.
Yes.
Okay, so like I said, I'm going to give a bit of a background to how surgery, obstetric, trauma, and anesthesia, that's what SOTA stands for, helps us attain UHC. We also look at a bit of the challenges what we're facing. I say that in the last 2 or 3 years, we've seen a big challenge in the shift of focus within the countries and in the global arena as regards what we're really going to work on in terms of healthcare, with the COVID-19 taking over most of our attention. And of course, in the last maybe 2-3 months, the war in Europe also is taking on a lot of our attention. During all this period, when we've had the COVID-19 pandemic, very little investment has really gone on into improving surgical healthcare like we had done when we started in 2015. But what is important for me is that we have had to sustain these services, even when we're going through a pandemic, even when most of the investments were going elsewhere other than the clinical support for surgical improvement. Now, it's important to remember how really surgery, obstetrics, trauma, and anesthesia helps in the attainment of the UHC. We know, of course, that there can never be UHC without surgery, obstetrics, and anesthesia being delivered to the people. And goal 3 of the SDGs, therefore, is the foundational goal that, on which all the other goals will depend. So indirectly, without goal 3, the other goals will not be attained. But we also know that the delivery of surgery, obstetric, and trauma and anesthesia at the district hospital can also indirectly reduce poverty. In our setting, especially in the low middle income countries, people need to use their limbs to work. And we know that surgical disease causes a lot of physical disability, which prevents them from any economic productivity. They need to grow their food. And so if we're going to end hunger in this part of the world, we need to make sure that the people are not disabled. The delivery of global surgery is a partnership, so it's a good place to start. Even the delivery, the professionals that are involved are diverse. Industrialization and infrastructure development, we need infrastructure development in the field of surgery, obstetric, trauma, and anesthesia delivery. At least that's a priority for us. If we're going to reduce inequity, again, this plays a key role. Even when you look at education, if children are born with disabilities, if they're not attended to, they can't go to school, they can never really get educated, they can never really move out of poverty. So indirectly, surgery, obstetric, trauma, and anesthesia has a lot of indirect influences or impacts on in the attainment of the SDGs themselves, besides the goal 3. When we zero into goal 3, we know from the targets that are highlighted with a red asterisk on your left of the screen, except for 2 targets, all these are actually impacted by surgery, obstetrics, trauma, and anesthesia. And so without this, there's no way we are going to attain anything in goal 3. And then if we can't attain goal 3, obviously the SDGs will remain a dream. What is important to remember also is that we're only remaining with 8 years before 2030. So we don't have too much time. And we can't say we'll work on this later. It's something that we have to start addressing now. Now, how can we really start taking advantage of this, and how do these things really link? Many of you have seen this picture before, which talks about the levels of care, and it also shows where we wanted to position the delivery of surgery, really being the district hospital, because we know even the delivery of UHC as a whole is anchored on the district hospital. The district hospital is the first referral hospital where if surgical capacity, obstetric capacity, trauma capacity, and anesthesia capacity is improved, we hope that we can deliver surgical care to everybody. It's actually also the safest level where we can provide the bellwether procedures that you know or you've heard of. But in the ongoing pandemic, it's also been shown that the pandemic exposed the weaknesses in the health system, especially at the district hospital. And the response has also spoken of improving the life support and critical care capacity of the district hospital. So basically, literally, and we know also that most of the tools that we've had to use during the COVID-19 pandemic, especially for the critically ill, because those who are not very ill stay at home, but those who are critically ill and those that are at risk of mortality have had to be admitted in hospitals or facilities, and these mostly have been the district hospitals. And the life support that they need to sustain the critically ill COVID patients are the same things that we need for emergency care and for critical care of surgical patients. So in short, we have to start talking about improving this capacity here because it has multiple effects. It's not only going to help us with the COVID-19 preparedness and response, but it also helps us with the life support that is required for critical care, emergency care, and operative care for the surgical patient. Now, how can we, vis-a-vis what has been going on, continue to advance SOTA care and highlight the importance of this in the attainment of the SDGs? First of all, from my side, I think that while the COVID-19 pandemic is going on, we still have to continue to talk about access because, like we said, while the COVID-19 was going on, many stakeholders really neglected the area of surgery, and yet we still had to provide surgical services to the people. Now, there is need, and even at the decision-making table, we were kind of cut off. The surgical community was kind of cut off in many platforms at the global level, regional level, even at country level. The technical working groups that are working on the emergency preparedness and response somehow in the beginning left out the surgical community completely. And they were struggling because, I mean, without anesthesia, how are we really going to keep people alive, even if they're suffering from COVID? So we realized that there is importance for us to continue to advocate for inclusion at the decision-making table. That's where the health policies are going to be formulated and the programs are going to run. Now, when I talk about inclusion at the decision-making table, it's also not just the surgeons or the obstetrician or the anesthetist. Let's remember the nurse. The critical care nurse is important, and we also must include them in our work. We shouldn't leave them outside. We have done that a lot in the past, and we should change that and ensure that the full team is on the table. The issue of access to health financing is important. Again, of late, we've seen a lot of money is going to other services other than clinical care. And even within clinical care, again, neglecting the issue of surgery. This issue is a major issue that's a stumbling block, which we need to address. And then, of course, we should continue then to talk about surgical care, which is, of course, should be of high quality if it's going to meet the criteria of universal health coverage. Now, one thing that is very key is that we've done a lot of advocacy on the global level, but we've really neglected the national level. At the global level, there are platforms that we can continue to talk about. There is the World Health Assembly, there's a United Nations General Assembly. We have regional committees that take place in each WHO region. We have economic blocks for us. We have SADC where we have to talk about. But the key thing that we have noted where we need to do more work is that the advocacy at country level and subnational level is very low. The awareness of all these movements and efforts that we're making is not well understood. And without the country level activity or advocacy and acceptance and inclusion, we're not going to make any way, because that's where the tires touch the ground. And so we should be able to try and ensure that the policies that are formulated at provincial level or state level and at the district level, and all the decision-making groups like technical working groups should include us in this work for us to make any effort on at country. I have already talked about the inclusion of nurses, and of course we should also include the patients themselves, because we can't be making decisions for them without them. Financing is a key stumbling block. Like I said, there are opportunities that are opening up that we should explore with development partners. But we shouldn't only look at development partners. The countries themselves within should look at how they can increase allocation or efficiently use what is already allocated to ensure that the surgical component of different systems or healthcare systems includes surgery. We should also be innovative. In Zambia, of late, we have, in the last 2 years, a social health insurance that's been introduced. It has been a game changer. Of course, it's not solving everything, but it's changing how we're looking at things. But again, results-based financing, value-based financing is something really we should consider. And surgery is a good area where this can be proven. This issue of financing is true even during emergency health pandemics like the one that is going on now. We shouldn't only talk about financing only when everything is okay. Right now we have the COVID going on, and we have to survive, and we have to live, and we have to provide good healthcare for everybody, even now during the pandemic. One thing that has really stalled how much funding has come to this area of work has been the fact that we have failed to prove the concept. Providing healthcare in a horizontal way, something that actually touches everything, touches all ages, affects all levels of care, is very difficult. It's not very easy. And as far as I'm concerned, we really haven't proven the concept of developing an integrated district health system that includes surgical healthcare. So we prove and show how it improves the health system, how it improves the health outcomes, and also how it contributes socioeconomic empowerment of the people. That we can do even in a small way through implementation research. And this is what is the good results that can come from such are the things that can also encourage those that can finance or invest in this area of work. Like I said, the access to surgery, obstetric and anesthesia should be looked at in forms of critical care, emergency care, and operative care. And really, it affects all levels. But the key for us should be the district, because that's where everything is meeting. And we shouldn't leave out the rural areas. We should look at entry points, looking at key populations or very strategic populations like women and children. We should look at the trauma patient. And then, of course, this service should not just be during good times. Even during now, when we're having emergencies, it's needed, and it should be timely. The challenges in going forward that we have noted that we must continue to address are the shaky global, regional, national, and subnational leadership and ownership in coordinating and formulating appropriate policies that can implement surgery, obstetric, trauma, and anesthesia. Not everybody has formulated a plan, not everybody knows how to do it, but it requires ownership and leadership, especially at country level. Without that kind of ownership and leadership, we are going to continue having problems. And without a policy, there is no way you can provide a service. Funding, again, remains a key issue that should be addressed. Let's prove the concept. Let's show the positive results, not only painting the bad picture. We have to show the good picture as well. What happens to people after they receive this quality surgical health care? What happens to the health system? What happened to the health outcomes? That needs to be proven, and then maybe it can help encouraging people to finance. And of course, the delays. We also have delays ourselves, like I already said, we ourselves as a surgical community should prove the concept. We shouldn't wait for funding to prove the concept. If we can prove the concept, we can encourage others to believe in what we believe and join us in the work that we do. Thank you, moderator. I think I can end there.
Thank you so much, Emmanuel, for that excellent talk. Gives us a lot to think about, shaky leadership, financing, etc. Next, we'd like to turn to Dr. Catherine Chu, SOTA Care Today. Catherine?
Thank you very much, Walt, and really thank the organizing committee for the opportunity to speak. I'm just going to share my slides, so let me know if and when you can see them.
We can see them, thanks.
Thanks, Teresa. Okay, let me just start here. Yeah, so Emmanuel gave a really nice overview of several of the different issues that are going on in SOTA care, and he defined SOTA care, so I'm not going to say the whole lengthy surgery, obstetrics, trauma, and anesthesia care. And Walt asked me to speak today on kind of where we are today. So Emmanuel touched on this, but obviously in the COVID era, things for many non-COVID conditions were pretty bleak. And for SOTA, our overall services were reduced dramatically globally. There are multiple papers modeling the millions of operations that were cut, especially ones that were considered elective, although in most of our part of the world and low and middle income countries, there were really no elective surgery. So cancer care, for example, was greatly reduced. And I think most places that would be not regarded as elective care. Both inpatient and outpatient care was reduced, and essentially only life-saving surgery coming through the emergency department was treated, especially in the early months. Also to mention that patients themselves were afraid to come to the healthcare facilities. So people who had abdominal pain, vague loss of weight, things that might turn out to be surgical conditions, also deferred working those up, but the outpatient clinics also were greatly reduced. And then, to say that, of course, SOTA care in LMICs is disproportionately under-resourced. And so, of course, during COVID, we suffered even more. Also to mention, because, of course, in LMICs, our access to PPEs, to COVID PCR testing, and then later rapid antigen testing, and then finally vaccines was also not as accessible or equitable as in the high-income countries. And And then initially, of course, to remember that there was a really high post-operative mortality reported. So this paper that came out in the Lancet in the first 4 months of the pandemic essentially reported a 30-day mortality of almost 1 out of 4 patients and almost 1/2 of patients with pulmonary complications. And I think that really made everybody very skittish. Since then, there has been a lot more data coming out of more countries. I think most of this came out of Europe, where the patients may have been older. And I don't think this is any longer the case, but this really influenced the desire for many hospitals to perform SOTA care. And then just to highlight some of the benefits of the COVID era, if there can even be any for SOTA care. So the importance of anesthesia and critical care was highlighted. And what was really interesting is that even in rural hospitals, critical care, like intubation skills, were improved by all the doctors. And also very interesting now, in many district hospitals, there's a surplus of ventilators. So I was just visiting the rural South Africa in the Northern Cape at a very rural hospital, and they showed me that they went from having 2 ventilators to now 25 because thanks to COVID. So just a few news examples: South Africa making their own ventilators, and then even in the UK, spent a lot of monies on ventilators, now no longer being used. But hopefully now many more cadres have been taught airway management skills, and I think that is an important skill that was been transferred. The other benefit, of course, is that during the COVID era, we learned a lot. And we learned a lot about COVID and SOTA care. So, in some hospitals, they established separate COVID theaters if that was possible, so patients that had tested positive. Just to say that COVID preoperative testing became routine once that was available in most parts of the world. Some hospitals had separate COVID circuits, so patients that were COVID negative would never cross paths with patients that were COVID positive with separate wards. And then I think that what's come out of this is that many countries have come up with frameworks for how to triage patients when the COVID pandemic is really bad. So in particular here in South Africa, we established our own national framework. And I know many other countries have, especially when the hospital is only able to do a limited number of operations. How does one decide which type of operations, which specialties would go first? And that has a lot to depend on, of course, the patients, the type of operations, and the resources needed after for post-operative care, like the ICU, which often was very limited given the number of COVID patients in the ICU. The next sort of thing about the SOTA today is the SOTA workforce, and probably don't need to mention to everyone here, but the inequity of distribution of the workforce worldwide is pretty remarkable. So the Lancet Commission on Global Surgery came up with a certain number of indicators to measure a country's robustness of their surgical system, and one of them was surgery, anesthesia, and obstetrics specialists, or density per 100,000. And they came up with a number of 40 per 100,000, and we don't really need to discuss exactly now how they came up with that, because I think that might not have been very precise, but I think as a comparison, for example, Australia, shown in light green, has more than the threshold of 40. And then if you look at South Africa, where I sit, we only have 12, so well under the number. And then the SADC region, which is a number of Southern African countries, the overall concentration is only 6.5 per 100,000. So one of our major challenges is a shortage of specialists that we have. But to acknowledge right off the bat now that the story about the workforce in LMICs is not just specialists. And I think it's really important to acknowledge that already in many countries, other cadres, both physicians and other types of providers, provide surgical care. So here in South Africa, family physicians, medical officers, so doctors provide surgical and SOTA care. Nurses, and particularly the anesthesia field, have been long in practice. Even in high-income countries, they're very well accepted cadre. And then the mid-level provider, sometimes called the non-physician provider, or the but now sort of the mid-level provider. So many African countries use this. clinical officers, clinical associates, técnicos de cirugía. They already provide a certain basket of surgical care. And so I think many people have written about task sharing or task shifting. I think the important thing about task sharing, but I know this isn't a lecture about task sharing, but it's just important to define the scope of practice, who can continuously mentor or provide supervision, whether that's remotely or on site, and what is the continuing medical education possibilities for this cadre. So I'm happy to discuss that if anyone has any questions during the Q&A. Of course, to mention that specialists, even and non-specialists that provide SOTA care are concentrated in the urban areas. And that's not just LMICs, of course. High-income countries also suffer from this. And so really poor access for the rural communities. And as Emmanuel is mentioning, the district or the first level hospital really should be the first point of entry for SOTA care. And in rural areas, there's often non-existent surgical capacity there. So I think we have a long way to go. The next thing is that who trains the SOTA workforce? And I think that one of the things mentioned, so the University of Global Health Equity in Rwanda recently just launched their Center for Global Equity and discussed in a panel the training opportunities or surgical education. And I think the things that came up is that number one, in LMICs, there's often few specialization opportunities. So many LMICs have medical schools, but the ability to train to be an orthopedic surgeon, a general surgeon, an anesthetist, an obstetrician are few in country. There has been a tradition of then finding the resources, the money to go to a high income country and do the training there. But the problem is that that's expensive and many people don't come back. There are some global south to south options. Here in South Africa, we have the luxury of having, for example, 9 general surgery training programs, and most of them have trainees from other parts of Africa that also come. Oftentimes our context, so the resources we use to train in are more similar to the trainee's home country than, for example, going to Belgium, the US, Canada, Australia to train. And then the third option that's been utilized by some is the in-country training by high-income partners, but who come and spend time in the country. The most well-known example of that is the Human Resources for Health program in Rwanda, and I see a few people on the call, like John Tarpley, who have participated in that. So that, just to give a summary, was an 8-year program where the US government sent specialists, SOTA specialists, including other specialists, to Rwanda in order to help train their residents there, but in country. And then just to mention, of course, the reason why it's probably not the best solution to go outside is the number of trainees that then don't come back home, thus making the disparity even worse. And even after training, many folks are encouraged or have incentives to go overseas. And so, you know, one recent trainee went to Canada to do a hepatobiliary fellowship, wanted to go back to his home country to build up surgical training there, as well as provide services for the people. But after a few years of frustration of not being able to set up the clinic, the operations, he then went back to Canada. So sometimes it's pretty challenging to even find the right work opportunity. So I'd like to end on that because I know that we wanted to save time for the Q&A, but just to say that, of course, SOTA care greatly was reduced by the COVID pandemic. The shortage of staff, especially in LMICs, makes addressing the backlogs really challenging. There's a shortage of training opportunities for LMIC SOTA specialists, and task sharing is certainly a viable option, but a clearly defined scope of practice, mentorship, and continuing medical education is needed. Thanks very much, and back over to you, Walt.
Thank you, Catherine. That was excellent. Next on the agenda is Dr. Mark Schreim, who will speak to us about SOTA and the SDGs and other things. Mark?
Thanks, Walt. Hold on, let me share my slides here. All right, can you all see my slides?
We see your whole desktop. if
You see
that's
my
okay
whole
with you.
desktop. Okay, let's stop that and try again. You read my emails, huh? Okay, is that better?
Perfect.
Great. So yeah, thank you all for the opportunity to speak with you. Thank you, Walt, for the invitation. It's interesting following on Emmanuel and Catherine's presentations here. I'm going to take a little bit of a different tack to this sort of background discussion on surgery, anesthesia, trauma, and obstetric care. I recognize that looking through the list of attendees, a lot of this is sort of preaching to the converted. And we've just heard two really spectacular presentations on what's necessary in surgical anesthesia, trauma, and obstetric care. So when Walt first asked me to talk about this, we talked about actually just a discussion of why we should be talking about surgery, especially in light of what we've just gone through, or what we're still going through in the COVID pandemic. One small piece of housekeeping: we've all been using different phrasing for surgery, anesthesia, trauma, obstetrics, nursing, perioperative care, biomed tech, sterilization, etc. I will probably just sort of slip into using the word surgery as a proxy for all these things, because if I tried to say all of them all the time, then my 9-minute talk would turn into a 27-minute talk. So let's not do that. To then kind of take a step back from what Catherine and Emmanuel were talking about, I'm going to take us to sort of a philosophical discussion of why we should even be caring about surgery and surgical systems. And let me bring in a voice from outside of the healthcare space. This is a quote that I ran across about 6 months ago in preparing a talk for a different venue. It's a quote from the late Polish author Ryszard Kapuscinski. And in this quote, Kapuscinski, who wrote a lot about development, says, "People are not hungry because there is no food in the world. There is plenty of it. But between those who want to eat and the bursting warehouses stands a tall obstacle indeed." Now, Kapuscinski is obviously talking about food here, but this metaphor of bursting warehouses in one place and people who want to eat in another place and a tall obstacle between them fits just as well for surgery. So in discussing why we should even be talking about this in light of a pandemic, let me actually turn that question on its head and ask, what sort of world would in what sort of world would it make sense for us not to actually talk about surgical systems? Is there a world that we could imagine that it would be a logical conclusion for us not to talk about surgical systems? And we could. It would be a logical conclusion not to talk about surgery if the following things were true. If there wasn't a large disease burden, if most people have good access to surgery, and if as a result of these first two, we're kind of on the flat of the curve for improvement, and any improvement in what's already there would simply be too expensive. And for a long time, Emmanuel alluded to this, for a long time, especially prior to 2015, 2010, this is where the global health conversation was with these sort of assumptions in the background. And on that backdrop is where Paul Farmer and Jim Kim wrote the single most famous sentence in all of global surgery, which is that global surgery is the neglected stepchild of global health. But the fact is, it should have been the neglected stepchild of global health if each of these things was true. It would make no sense for us to devote our time, our energy, our money to things that don't treat a lot of disease burden, people don't have a lot of access, that people do have a lot of access to. We should instead be spending our time, our money, our energy on things that give us more bang for buck. Things like vaccinations, bed nets for malaria, antiretroviral therapy for HIV. So the kind of ignoring the neglected stepchild status of surgery wasn't some sort of nefarious conspiracy to keep surgery on the sidelines. It made sense given what we thought about surgery at the time. But the question then is, are these things true? And the fact is, they weren't pulled out of thin air. They are actually supported by some research. And I get really uncomfortable when I present this particular slide in talks, because I'm about to highlight two papers in surgery that come from two people that I deeply respect. So highlighting these papers is in no way an indictment of the researchers themselves. In fact, the first paper I'm going to highlight is from Haile Debas, whom I firmly believe, if it weren't for Haile Debas and others like him, we wouldn't be sitting in this room talking about surgery right now. However, in 2006, Debas published what became a fairly famous paper estimating that 11% of the world's disease burden is surgical. Now, that's a fairly big number, right? Because that is the same disease burden attributable to HIV, TB, and malaria. It's a fairly big number until you think about the complement of that number. If 11% of the world's disease burden requires surgery, that means 90% of the world's disease burden doesn't require surgery. 4 years later, Funk, Gawande, and others looked at the global distribution of operating rooms and found that 2 billion people around the world don't have access to an operating room. Now, in the kind of bizarre, broken telephone way that research disseminates itself into the ether, 2 billion people without access to an operating room became kind of morphed into 2 billion people don't have access to surgery, which again is a huge number until you think about the complement. That would mean that 5 billion people do have access. So if 90% of the world's disease burden doesn't require surgery and 70% of the population has access to surgery, then it absolutely makes sense that we shouldn't be talking about surgical systems. Now, we all know, these next two slides are slides that you all know and have seen a dozen times. We know that Funk and Gawande's paper was not just looking at access to surgery, it was looking at one domain of access, which is the domain of availability. And who cares if there's an operating room near me if I can't get to it in time, or if the surgery delivered there isn't safe, or if I can't afford it, the things that Catherine and Emmanuel were just talking about. And we know that if we look at these 4 domains of access, that number flips and that it's 5 billion people that don't have access to surgery. We also know that it's not 11% of the disease burden that's attributable to surgical conditions, it's 30%. 30% of the world's deaths, 30% of the world's DALYs are attributable to diseases that should interact with a surgical system at some point in their disease course. Now, a distinction here is that not all of those conditions actually end up in the operating room. And that gets to kind of why it's important to have surgical systems in place, because sometimes diseases that require interaction with the surgical system don't ever actually get into the operating room. The ability to not operate is a privilege of having a surgical system. These diseases, these conditions distribute themselves across all disease categories. Many of you have seen this slide before. We as a global community have made a commitment to decrease maternal mortality to less than 70 maternal deaths per 100,000 live births, which is an awesome commitment that we will fail at without surgery if 35% of maternal admissions to the hospital require surgery. We won't make a dent in cancer mortality without surgery if 62% of cancer admissions to the hospital require surgery. By comparison, this is where the global health conversation was for a long time, where some of the global health conversation still is, and actually where COVID has kind of pushed the global health conversation back to, which is back to infectious diseases. And if we're focusing on infectious diseases, we obviously don't really need surgery. Look at how small those bars are. They're not zero, but they're also not large. It makes sense, again, not to be talking about surgery if we simply ignore the huge burden of disease that actually requires surgery. One last point in this talk, that's a burden of disease that's only going to increase. Many of you in this room will know about the epidemiology transition because this theory has been around since 1971. It's 51 years old. In the original paper, Omran theorized that as healthcare, as public health measures, sanitation improved, then the crude death rate in the country would go down, leading to an increase in the population of the country, an aging of the population of the country, and then later the crude birth rate would follow. And because healthcare, sanitation, et cetera, was improving, infectious disease would recede in importance. And what was called degenerative and man-made diseases, what we now call non-communicable diseases, would increase in importance. Now, that was the theory. Now, I'm stealing this next slide whole hog, absolutely completely from a talk that Dr. Agnes Binaglaho gave to our CSI just last week. It's not just a theory. This is actively happening right now in sub-Saharan Africa. In these two figures, Dr. Binagwaho shows that the two figures are proportion of deaths attributable to each disease category and proportion of disability-adjusted life years attributable to each disease category. Purple at the top is infectious disease. And we see that going down. Now, we will probably see a blip going back up in that due to COVID before it continues to go back down, while non-communicable diseases in purple are starting to increase in importance. So let me end then with this question. Why should we be talking about surgery, especially in the middle of a pandemic? Because without surgery, population health is frankly unattainable. Without talking about surgery, anesthesia, trauma, and obstetrics, we'll do nothing to drop that tall obstacle between the people who want health and the places where health is being delivered. Thank you very much. Walt, back to you.
Thank you, Mark. That was outstanding. Gave us a lot to think about. Thanks to all three panelists. Those are excellent talks. And now I'd like to open it up to some questions that anyone in the audience may have. We've had a couple of comments in the chat. One from Dr. Key Park asking about, with so many extra ventilators around, why can't we send those to low resource settings? Would you like to elaborate on that, Keith?
No, it was just a, by the way, the three speakers were amazing and made a compelling case for surgical care. I think it was Catherine that said there may be excess ventilators now, right? And so if that's the case, would it make sense to try to redistribute those with excess capacity to places where they're actually, they need more, right? Places where they're building up surgical systems. And I think, I'm not sure if I'm saying this person's name correctly, Stuzani had a much broader question about redistribution of resources.
Thank you. Yes, Duzani, you've had a couple of questions. I'm sorry if I'm not pronouncing your name correctly. Would you care to comment?
I think those in the audience don't have audio.
Oh, okay.
But if you want to read, we can read the question.
Sure. First of all, Stuzani says that pandemics such as COVID remind us of the importance not only of both collective medicine, standardization, management protocols, and personalized medicine, but also dynamic strategies such as redistribution of resources. How can SOTA task force help with the aftermath of all the reported surgeries? Anyone care to comment?
I'm happy to take a stab at that, Wolf.
Okay.
So, I mean, I think that I can only answer for our own experience here in the Western Cape, in Cape Town in South Africa, where we have, like many places, a huge surgical backlog. So the provincial health team is trying to figure out how we can address that. And I think that simply sending in resources, and most of the time that means human resources from high-income countries to help kind of do service delivery, like surgical camps, I don't think it's actually the solution, because one of our problems is just a shortage of operating theater nurses and operating theaters. Because now that we're sort of almost back to business as usual, we still have all the normal cases that come in, but we have these huge backlogs of, hip replacements, cancer cases, but where to put them. So even if you have many of the local SOTA teams volunteering their time, which they are, you can't find enough operating theaters and then nurses. And so you cannot just import all these people because they have to be licensed to work here and things. And of course, I think that the more important thing is that we're trying to learn now is how can we improve our surgical health system whilst trying to address the surgical backlog. So not just as a Band-Aid solution, but if we're short of operating room nurses, then we just need to train more. So we need to invest that. And I think that what COVID did is just pull the Band-Aids off all the weaknesses in our system which now we need to address in sort of the longer term. So I guess to me, it's not as simplistic of an answer. And then just to say for key, like we have these hospitals that have like, 20 ventilators, but no ICUs and no operating theaters. But, the ventilators aren't used for the operating theater because that requires an anesthesia machine as well. But, they don't have all these ICUs. But the problem is that now almost every single small hospital in South Africa has these. So we don't to whom do you give them? Yeah, thanks.
Can I hop in here, Walt, also?
Please.
One of our colleagues, Embreen Slimi, who's a obstetrician gynecologist, uses a phrase that I've stolen. I steal things from people all the time. I've stolen, she calls it the junk for Jesus problem. That there is this idea that, well, we've got a bunch of ventilators, so let's just send the ventilators over there. In the end, if the ventilators have no biomed techs to support them, as Catherine has said, have no sort of anesthesiologists to use them, we've basically just sort of donated junk so that we feel better about what we're doing. To highlight Emmanuel's point, surgery is annoyingly horizontal. It just resists these sort of vertical interventions. We have to work across the health system. It makes it slow, it makes it hard, it also makes it really interesting. But it means that these shorter term interventions, whether they're ventilators or as Kat's saying, whether they're short-term surgical trips, their utility has been decreasing over time.
Thank you. Emmanuel?
Yes, just to add to a little bit of our experience during the COVID-19 and surgical services. As the pandemic really approached and we were seeing a lot of waves, like we said, most of the resources coming from government and all their partners really went to public health about prevention and later on went into vaccinations and stuff like that. We didn't really see any support for surgical care. And so we were struggling, we were fighting for ICU space, to keep our surgical patients alive. We were struggling to kit ourselves with protection, including just face masks. And so for us, we had to really go and lobby our partners in the high income countries to support us. And I should report here that we got a lot of support from the government of Scotland, working with an NGO called CUGH. They provided us so much PPE, and they also provided us with, because we realized that we couldn't just protect ourselves, we also needed to take care of our patients. Like I said, we were struggling for where to put our critical patients, surgical patients. We didn't have that. All the spaces in ICUs and all the equipment was used for COVID. So they sent us some oxygen concentrators that we used to keep our surgical patients alive, even within our surgical wards. They also sent us a few ventilators. And these, of course, we had to be strategic on how we distributed them within the country. We prioritized training sites because, first of all, our priority as a professional association was to kit and protect the health workers because we didn't know much about how COVID would affect us ourselves. And so we supported the training sites, but when we started receiving much more material, we then went to the second level hospitals, and then this was going to flow down to the district hospital. Unfortunately, we had to do the top-down approach. But ideally, we think and we feel that every district hospital should have the critical care capacity to care for any patient that comes there, whether they are COVID or a surgical patient or an obstetric patient, as long as they need life support. Now, this capacity does not exist at the district hospital. So there is room for all those materials to be distributed and to be used very well. Of course, they have to go with training and they have to go with backup maintenance, because again, sometimes we collect so many gadgets and then they break down because of a fuse and then nothing happens forever. Yeah.
Thank you, Emmanuel. Catherine DeVries had a question and it's disappeared. I guess it's been answered by how can we build and support more theaters with trained staff? Does come back to political will to pay? What about the private sector? Catherine, I believe you answered that one, but do you want to expand on that a little bit?
Oh yeah, I mean, I think Catherine is alluding to the lack of political will, and I would agree. I think that, it's like they recognize that there's a huge backlogs during COVID, and I think even the public is demanding they get their operations, and so they turn to the SOTA providers and say, okay, can you provide more? But we don't want to give you any extra finances, or maybe we can give you some for 6 months. And I think they also had that sort of increased service delivery idea, like everyone just ramp up for 6 months. But I think all the practitioners recognize the longer term issues, especially if you need more theater staff, you got to train them and have the salaries to continue to hire them, which we didn't have. And then for us, at least in South Africa, our private sector functions completely separately. Unfortunately, the public sector isn't able to buy out surgery that the private sector could do. The only example of the private helping out the public, or the public being willing to pay the private sector, was during COVID, when we really needed ICU beds, and the private sector put a price on ICU beds per day, and then the public bought those out. So maybe that's, but hasn't carried over into surgical care so far.
Great, thank you. We have
Catherine,
one last.
sorry. Oh, sorry.
Yes, go ahead, Mark.
I was just going to say, it's interesting to hear you answer this question. A lot of us are coming from ministerial, academic, approaches to these things. But what moved things in South Africa during COVID was public pressure. So we can do a lot of what we want, and do all the research and the policy making and the agenda setting. But the real pressure is going to come, I think, when the public in any country demands improved access.
Absolutely. There's nothing like political pressure. Emmanuel?
It's the only other contribution that for me, I see the public and the private sector contributing to the whole issue of surgical care, at least at country level, is when, of course, like Catherine said, where there is readiness to pay for it. The private sector offers things for a fee. They can't offer it for free. Somebody has to pay for it. And so we know that there are NGOs, for example, that support a lot of care in other fields. They could also support surgical care in the private sector at country level. NGOs can be set up that can support that, because we know that in the other fields, in infectious diseases, in HIV, there are programs that are financed that actually provide or support things like that. The other thing also is that most of the low middle income countries spend a lot of money on sending people abroad for care, and most of these patients are surgical. They could be cancer, they could be something else, but mostly surgical. All these monies could be spent locally if the private sector at home or at country level can be improved. Because that investment then, or the money that is spent, even if it's in the private sector, but at least it stays within the country. So that's another role that the private sector can play. But like I said, it's still, it's something that should be paid for. It's not something that will be provided for free.
Well, thank you very much, Emmanuel. We are out of time. And there was a couple of other questions. I'll try to type some answers, or anyone else can answer them if you like. But I would, again, very much thank my panelists for your excellent talks, for your contributions. And I will turn this back to you, Dr. Chin.
Great, thank you so much, Dr. Johnson and all of the panelists. That was really such a great session on the background of SOTA and universal health coverage. So just to kind of give an update of where we are now. So now we're going to start our second session, working together towards strengthening surgical systems. And we've got two moderators. We're really fortunate to have new leaders moderating this panel discussion. Sarah Hill is a research fellow in Harvard's program in global surgery and social change, with a background as a surgery resident at the University of Toledo. Srinik Kundu is also a research fellow at the program in global surgery and social change at Harvard Medical School. He completed his medical school and went on to earn his master's in experimental and global surgery from McGill University. So without further ado, Dr. Hill and Dr. Kundu.
Yes, thank you so much, Terry. All right. So welcome to the second of our 3 sessions CUGH 2020 satellite event, the essential role of SOTA care in advancing global health. We just finished a fantastic session moderated by Dr. Walt Johnson, for those of you just tuning in now. Now that we've heard about some of the current challenges we face in achieving SDGs in the context of SOTA care and universal health coverage, we will discuss the importance of partnerships in surgical system strengthening. Our next session focuses on the importance of diverse stakeholders in advancing SOTA care. We are fortunate today to be in the company of a fantastic panel with backgrounds in SOTA care in the Asia Pacific region. A huge thank you to our speakers for being here with us today and sharing their insights.
Thank you, Sarah. And before we introduce our panelists, I would like to remind you that this webinar is being recorded. And I also want to encourage to submit your questions using the Q&A section, and we'll get back to you at the end of the panel discussion. If anything we discussed today speaks to you, then you can tweet and post about it and tag us and use the hashtag as we showed here. Back to you, Sarah.
All right. Today, I have the pleasure of introducing the Honorable Minister, Dr. Wankambete, who is Fiji's Minister for Health and Medical Services and President of the Pacific Island Surgeons Association. Before entering politics, the Honorable Minister was a general surgeon in Fiji and Associate Professor of Surgery at Fiji National University.
It's my pleasure to introduce Dr. Liz McLeod, who is a pediatric surgeon from Melbourne, and she has been engaged with the Royal Australasian College of Surgeons Global Health for 15 years in the Pacific and Southeast Asia. She has an MPH with a research focus on program design and evaluation, and is currently a consultant with the World Health Organization, advising on the implementation of the action framework for safe and affordable surgery in the Western Pacific.
And finally, Dr. Key Park is the Director of Policy and Advocacy at the Harvard Program in Global Surgery and Social Change. He's a member of the Expert Advisory Panel on Surgical Care for the World Health Organization and the co-director of the WHO Collaborating Center on Surgical Systems. All right, so to kick off this discussion, I'd like to direct a question to Minister Wanka. To what extent is SOTA care a priority for health ministries and funders?
Thank you. There are 5 important things that I feel why SOTA care is important for ministries and also funders. First of all, SOTA care is a significant consumer of resources in healthcare settings. Now, the US suggests that inpatient surgical care represents nearly 50% of the hospital expenditure and 30% of overall expenditure costs. This is believed to be an underestimation, as outpatient surgical costs have not been considered. In Fiji, in 2015, we did a national health accounts, and we found that about 60% of current health expenditure is taken up by curative health services, which includes SOTA care. And this trend remains today, and also, as just like the US data, may be underestimated. And so you can see that, and I was looking with interest in the first panel where Mark talked about the disease burden of surgical care diseases being 11%. But you can actually see that the actual cost to the surgical systems and in a country such as Fiji can be anywhere in between up to 60%. And therefore, it is a great consumer of resources. And thereby, there is an argument for strengthening SOTA care. 2, SOTA also addresses the most economically productive in the community. And low middle income countries such as Fiji, we are dependent on our labor-driven market. We're dependent on the workers in the tourism industry. We're dependent on those who are helping in development, building the roads. And so, for example, if some of them are not able to do their work properly because their quality of care are hindered by something that can be affected or intervened by SOTA care, then they cannot work productively. And so, for example, even in Kenya, and we've seen in Fiji that by taking outreach services into the community, by taking the hospitalship into our maritime areas and being able to just do a simple hernia repair or provide a tubal ligation for a lady who, who needed to be able to stop pregnancies, that this actually supported the economic development and overall supported the community and also the nation as a whole. So second one is it is supporting the economically productive age groups 15 to 44 and also the women in the reproductive age group. Thirdly is SOTA care is an indicator of quality improvement in the health system. And it's linked to obviously the governance framework in health ministries. And the processes for SOTA care includes infection prevention and control, operating theatre services, sterilization services. One thing that we've done in Fiji throughout COVID was to say, by the end of COVID, we will develop resilience dividend. We will actually be stronger than we were before. And as a surgeon and also as a minister, one thing that I'm absolutely proud of is the fact that we can actually begin to strengthen and continue to strengthen our infection control processes. Because surgical site infection, even though small, can be quite debilitating. They can really add to the amount of days that people are admitted in hospital. So, finding ways in which we can be able to strengthen the whole health system through SOTA care. And, theatre is in the heart of the hospitals. To be able to get a theatre running, you must have your sterilization systems running. You must have the ability to be able to have oxygen and so forth. So the other argument for SOTA care is by strengthening SOTA care, you are also strengthening your health system and the quality improvements in the health system. Number 4 is SOTA care represents the rapidly developing technology in the cutting edge of medicine. And somehow in low middle income countries and countries such as Fiji, you wonder, where is the balance? Where do we begin or where do we stop? Do we get the next? Do we look at robotic surgery, or do we stay with what we have? But what we found is that you have to make an investment in important technology to be able to effectively and prudently deal with surgical and obstetric patients, and that has to be done. So, for example, instead of having 5 theaters and 3 diathermy machines and sharing everything in the 5 theaters, you need to make investment to make sure that all the theaters have anesthetic machines. They also have diathermy machines, but they also have a redundancy in place. When one does go wrong, you can actually replace them so that you can continue turning over your patients. So, as I've alluded to, the other important thing is actually making sure that you have a cutting edge of medicine, but finding the right balance. And 5, SOTA care has significant social and emotional impact on the community. There's a lot of embarrassment when somebody has a hernia, has a hydrocele in the community, their inability to be able to participate in community work, their inability to be able to be leaders in the society and also in the villages where they're in. And so the fact that we were able to deal effectively with them through a simple operation makes them not only economically stronger, but also able to participate in the social hierarchy in which they exist. Thank you.
Thank you. Thank you so much, Minister. I would like some inputs from Key as well. Like, I'm sure you have something to say about the how the priorities of health ministries and how you've worked and about your experiences.
Well, thanks, Srinik. Minister Wanka, it's great to see you. I mean, the theme of our session is about working together, right? I remember, first of all, having a health minister who's a surgeon is a huge bonus. I think there's no question. But when we had a chance to be involved with the Fiji stakeholder meeting, this is so clearly the building up of surgical systems in these countries requires multi-stakeholder involvement. You got to go as a team. We're not going to fix this out of a surgeon's lounge, thinking. They had a broad array of stakeholders, including, I think someone mentioned, civil society. They had a civil society representative there representing patients. But more importantly, throughout the government, the Fijian Health Ministry really worked the different silos. In fact, I think it was the Prime Minister himself came to the stakeholder engagement meeting and opened up the meeting. To me, that's the kind of partnership and teamwork that will drive successful surgical system strengthening. I think Fiji is a great example of that.
Morning, everyone.
Yes, Dr. McLeod, yeah. Please go ahead. I'm sure you have.
Could I just add to what Key just said about multi-stakeholder and Fiji demonstrated this as well, but I think it's really important that not just multi-stakeholder within the health services, but multi-sectoral. So I really need to engage with ministries of finance, and I'm sure Minister Wanga can speak to that much better than I. But there's been a lot of discussion around financing. And so it's really important to have finance involved right from the start, but also given the current global context of lots and lots of different things happening and pulling resources in all different directions, we need to be engaging in a wider sense as well. Civil society, really important, and that's been identified as a big gap, which I'll talk to in a minute. But also thinking about bringing in people from climate change ministries, disaster risk reduction people, and so forth. It's just, I think we're at the stage where we really need to be broadening the frame in the way we think about surgical system strengthening. Thanks.
Right. If nobody has anything else to add, we'll go to the next question. As we were talking about gaps, I would like to direct my next question to Dr. McLeod. That what are the key barriers to SOTA care, and how can we overcome them? Like, we have heard you talk about the lack of leadership, and we have also heard you talk about the failure to present as an organized front. But how can we go ahead, and how do we overcome these barriers?
Yes, I talk, well, the part of the last session that I dialed into seemed to cover a lot of things that we'll cover in a recurring way, I think, in this webinar. But I think that some of the barriers have changed since 2015 and Resolution 6815. But wow, hasn't the world changed in that time? I think we've made great strides in changing the perception of surgical care, and that's thanks to the tireless advocacy of people like the late wonderful Dr. Paul Farmer. And this was a huge barrier, but I think that perceptions around surgery have changed. As for other barriers, I think these are really context specific. We're all familiar with the Lancet Commission metrics and probably also the 3 delays framework, which I think is a really useful tool for identifying barriers to accessing surgical care. So for any context, you can identify which areas are particularly problematic, maybe cultural hesitancy, geographic access problems, such as those experienced in small island developing states, And then, of course, all the problems that occur after you arrive at a facility, workforce shortages, consumables, infrastructure, and so forth. I'll mention the financial risk protection barriers because these illustrate really well where we are currently, I think. For the Pacific, we've got really good Lancet metric data, and that includes some very sobering metrics 5 and 6 that were collected by patient survey, and they show really devastating rates of impoverishing and catastrophic expenditure from seeking SOTA care that are higher than those modelled by the World Bank and are largely related to non-medical out-of-pocket expenses. And I'll just mention a concept that I find really useful, and that is a concept of the cycle of fragility, in which exogenous shocks are applied to a population or people. So it might be a sudden onset disaster, such as Tonga's just had a big volcanic eruption, add in a pandemic, and these events are occurring with such frequency that they overcome the ability of people to rebound and recover from these events. So in the current context of the pandemic, where the minister's already alluded, we've had a big drop in GDP in many Pacific Island countries with closed borders and loss of tourism revenue. So when additional shocks occur, financial risk for people just becomes insurmountable. They've lost their regular income streams and so forth. So an example of this is when Tropical Cyclone Harold hit the northern province of Vanuatu in April 20, just after the borders had closed. There was this very significant disruption of maritime transport in the province, and providers jacked up their prices around 3 times, so triple-fold increase in the cost of travelling to the referral hospital in Luganville. And that just meant that many patients simply suddenly couldn't afford to access care. So I also really like the notion of robust surgical systems adding generic resilience for people and providing a layer of security that helps to buffer against all these shocks that are occurring. So with our current situation of multiple complex crises all happening at the same time, I think the barriers to care are greater than ever. And I think that the global surgery movement has made great progress, but we are at very significant risk of losing everything that we've struggled to achieve so far. As to what we can do about this, I think the biggest thing we can do is what we're doing right now, and that is being together and collaborating and seeing things through each other's eyes. When I was doing my Master of Public Health, I came across some work by a policy guru called Jeremy Schiffman, and he's now a public policy academic at the American University in DC. And he compared the low level of traction that was gained by the Safe Motherhood Initiative, which took off in 1987, and compared that with the huge success of UNICEF under the leadership of James Grant. And he developed a great framework for determinants of political priority and included active power, and that's what people have already been talking about tonight, the policy community cohesion, leadership, civil society mobilisation were all elements of active power. And then really importantly, the framing of ideas and how ideas are presented externally, so to the public. Then political contexts, utilisation of policy windows that may open, and the global governance structure to support an initiative are all critical. And he's more recently, in 2015, applied this framework to global surgery and came to the conclusions that I've already heard mentioned, which is that our main barriers as a community are related to leadership, We're very fortunate in the Pacific to have very strong surgical leadership, and our failure to present an organised front, so a cohesive community. And also we've had very limited efforts to include patient voices and the voices of civil society. And a really good example of this, of our failure to present a united front, and I think I might have mentioned this in a previous event, is the Global Initiative for Children's Surgery meeting that was held in Vellore in 2018, which seems a lifetime ago, where after 3 days of really robust discussion, we failed to agree on a set of paediatric bellwether procedures. So that's just an example for me of actually how difficult it is to formulate the kind of cohesion that the Lancet Commission were able to pull together and present to the world in 2015. So while I know it's, I find policy as a concept a weeny bit boring, but advocating for SOTA care, it's so important that we get surgical care enshrined in policy. And in a study published 2020, I think, looking at the national health plans in 12 Pacific Island countries, none of them, literally none, specifically mentioned surgical, anaesthetic, procedural obstetric or trauma care. And if it's not there, it's not going to be funded. So we must make sure that we're at the table when our national health sector strategies are being drafted. And Minister Wanga will be able to speak more eloquently to this about the Fijian progress on the National Surgical Obstetric Anaesthetic Plan, but 5 Pacific countries agreed to pilot the NSOC process with the assistance of PGSSC a couple of years ago, and that process has been significantly disrupted by the pandemic, but is underway. Of course, making SOTA care a political priority it's not sufficient to address all the barriers that exist, but political priority basically equals money. And without that, it doesn't matter how clever we are in reimagining surgical systems and fitting pieces of our complex ecosystems together, we'll not be able to affect change, particularly as we're now competing for precious resources with other priorities such as the pandemic and what will be the increasing frequency of exogenous shocks related to climate. Thank you.
Thank you for your exceptionally comprehensive response to our question, Dr. McLeod. I was wondering, Minister Wonka, if you have anything to add regarding barriers to SOTA care.
We have talked about the barriers, and again, they're quite well known to us, and the last panel talked about them also. I just want to see and discuss some of the barriers and also the opportunity that exists. One, we've talked about how it's important to have a political will. And, you know, I'd really like to encourage surgeons and obstetricians and anesthetists to actually see this as also an important part of our career development. My humble personal experience has been that in a low middle income country, you will not be able to change what comes into your operating theater unless you step into the political realm. And some of us will have to make that important career choice. Some may look at it as a sacrifice, but it is important. Why is it important? Because political will drives the policy of the nation. The political will drives the National Development Plan, the strategic plan, the annual operating plan of the Ministry of Health. And funders look towards those plans. And so when you are on the periphery, you can talk with funders as much as you can, bilateral funders and multilateral funders, but they will still go back to the Ministry of Health. They will still go back to the policymakers. And the policymakers will then decide whether what we as an organization have decided is important or not, based on the political will of the policymakers. So that's first and foremost. And you know, really, again, just encourage us, surgeons in low middle income countries and also in high income countries, that we need to step into those areas and you know, and drive policy. Secondly, is that some were similar, somehow similar to what Lisa talked about. Liz, you're a trooper. There must be 3 o'clock in the morning in Australia. Is that we need to have surgery in every discussion. So whether it's about disaster response, whether it's about climate change, we need to be able to find the surgical narrative to put it into that discussion. Because what happens is, when there's a recurring theme, then that becomes something significant, and discussions are carried in depth in that particular area. So an example from Fiji's experience is after every disaster with our emergency medical teams, we always make sure that we have surgeons and anesthetists and obstetricians part of the response teams. And so they go out into the communities and they find people that, you know, they have some issues with communicable disease post-disaster, but they surely find those who need a hernia repair. They surely find those women who will benefit from an elective cesarean section rather than waiting to deliver out in the rural areas and maritime areas. And so we need to be able to, you know, penetrate through into those areas of society so that we can actually, we are more relevant. So in my community visits, I go into the communities. I was up in the Highlands yesterday, 2 hour drive from Suva. They said, oh, thank you. You know, we, in the team that came here post-disaster, they had a surgeon that came here and he found some people with some surgical conditions and organized them, and they've had an operation. So, you know, we have to be willing to go with the public health teams. We have to be willing to, you know, go with the outbreak teams when there is an outbreak. Mark had talked about in the previous discussion again about how you know, we're shifting away from communicable disease to non-communicable disease, and it is a sign of development of a nation. And developing countries such as Fiji, we're stuck in between the two. We still have communicable diseases. We still have some challenges with WASH. We still have some challenges with leptospirosis and dengue. And then we also have non-communicable disease. So what I commonly say to the surgeons and to the obstetricians is, don't wait in the hospital because you're not able to operate, because the hospital is filled with people with acute febrile illness. Go out into the community, be part of the public health teams, mitigate against communicable disease, and find the surgical patients. And you're doing both. You're actually helping to reduce the number of communicable diseases, but you're also being able to find those that we can deal with effectively with their surgical conditions and make their quality of life better. And lastly, that what we also have to realize is that multilateral fund partners and funders, not only do they look at the political will, they also want to see what is your track record like. What have you actually done over the last 1 month, 6 months, 12 months? just being frank here, is that you can't come to the table with a multilateral partner and say, hey, we were part of the great Lancet Commission in 2015, and we have a 2015 data. That doesn't happen. You need to be able to tell them this is what we've done just recently, last week. Last week, we had a surgical outreach team in the maritime area, and this is what we did. Last month, this is what we did. Last 6 months, this is what we did. And I think we need to understand that as much as surgeons, obstetricians, and anesthetists, we talk about best practice in clinical medicine, multilateral partners also want to hear best practice and current practice. And what is your latest evidence of what has been done? Because based on what you have done recently, they will then support you with the next funding scheme. And I believe this is a very important thing that I've learned as a minister of the last 3 years, is that we can't rely on what we've done 5 years ago, 6 years ago, and bring it to the multilateral partner. When you tell them that you're doing something current, they see the current pictures, you take them to the current site, you show them the current facility, you show them the current process. That makes them excited, because multilateral partners are awakened by what's happening today. Thank you.
Thank you, Minister. Moving on to our next question, and I'll direct this at Key. In what ways can we work together to strengthen surgical systems in LMICs? And I expect that everybody's going to have some input on this, especially since we've already touched on it in answering some of our previous questions. But Key, go ahead.
Thanks, Sarah, for that question. First of all, there's a very active chat going on. And I got to tell you, Keith, we need to hire you as the global surgery political consultant. We need to bring you into our community. And I think it's your political background, of course. But, global health is fundamentally not a question of technical solutions. We know how to do these operations. These are not hard operations. They're providing that. It's not even a question of money. Mark, the beautiful quotation that Mark put up, there's plenty of money around the world. We know that. But it comes down to politics. And Minister Wonka really alluded to that, right? How do we get there? So let me give you some examples of how to use our teamwork to drive some of these political priorities. So I just remember, and I'm going to focus on Fiji because Minister's here. 3 years ago at the World Health Assembly, Minister, you and a number of other health ministers organized a side event at the Palais at the World Health Assembly, and Walt was there, and it was specifically looking at the surgical care in the Western Pacific region. And that was a powerful meeting because immediately after that side event, I remember getting a text message saying that Regional Director Kasai is planning to put surgery on the agenda, at least as a provisional agenda item for the fall meeting in Manila, and which, as you know, the agenda, the safe and affordable surgery became an agenda item, and now there's a regional framework for action for safe and affordable surgery for all member states. And WHO Manila office is allocating resources and personnel to support member states in this. This is an important political process, and you need to get other people in on it. The other thing is the teamwork that went into driving USAID. Well, actually, I should take one step back. U.S. government and directing USAID to support surgical system strengthening. That just became law just a week ago. President Biden signed into law, and the language specifically says USAID should try to reduce these specific surgical conditions, cleft palate, club foot, traumatic injuries, those kinds of things. But the other part is USAID shall support surgical system strengthening efforts. So we have this, within our network, an effort to try to advocate for funding from these, USAID and other entities. But we also work with health ministries in the LMICs like Fiji, and there was this sort of a push-pull strategy, which is, we're going to push from the funding side, but Minister, it'd be great if you can get a message to the USAID office saying, hey, Fiji is interested in surgical system strengthening. It'd be great that if USAID can help us with this initiative. So you got sort of a complementary action that hopefully will result in additional funding and resources from USAID. I can tell you, we just had a call with them this morning, the USAID people. They are very interested in surgical systems at this point. So it remains to be seen how that plays out, but they're very interested in discussing this further. Now, I do want to talk about this point that Mikasa brought up here, which has to do with a proof of concept, and that Minister Wonka talked about, the fact that development finance institutions want evidence, right? They want data, they want information as to what would be investable, what would be fundable. As far as I know, there has never been a system-wide intervention for strengthening surgical systems because it's complex, right? But it's inherently very complex. But we assembled a working group at the PGSSC, and many of you in this group, in this meeting, are part of it. And if you want to join, and please just let me know, specifically to identify a number of interventions we think will be useful and valuable for strengthening district health level systems. And I know, Mikasa, you put in a very, very good idea. But when we looked at these ideas, and we had initially planned to pick top 3, right? Vote on the top 3 ideas, interventions, and then maybe send it to the USAID for some suggestions. But when we looked at it, they all actually they fit better as a consolidated framework. These interventions, for instance, workforce training, improvement of patient safety using checklists, supply chain issues, data collection and registries, improve informatics for referrals, mobile surgery units. All these things actually work better if you bring them together into a district level health system and make them fit well into a coherent, a consolidated framework. So once again, we have to work as a team to succeed. And then what these interventions also do is that they allow funders with specific mandates. For instance, USAID does not invest in infrastructure. We're just told that this morning. Great. CUGH, on the other hand, is willing to pay for infrastructure. So if CUGH takes this chunk of the district health system strengthening in surgical care, then USAID can take another chunk. So this once again brings in a number of funders and allows them to work together in a crowded in type of funding scheme. And most importantly, we would love to see these kinds of district level surgical system strengthening initiatives in a number of countries, maybe 10 countries, maybe even including in Fiji. And I know Zambia is very interested. And then we learn from it, right? We do 10 countries in a row at district level, and we get some data, we get some proof of concept. Once again, we have to work together to achieve this thing. So let me just stop there. Thank you.
Could I just chip in on the district level, and just to say that that's a real focus for WHO, and the action framework is building from that level up. So that's the WHO, the current WHO focus for the Western Pacific regional office anyway. Thanks, Keith.
The chat. So one of our visiting scholars came up with this acronym, the DISSECT framework. And it stands for District Level Interventions to Strengthen Surgical Ecosystems, a Comprehensive Theoretical Framework. More to come. And this is a consolidation of all the intervention ideas at the district level that the working group contributed to.
Wow. Thank you all for sharing your experiences. And I can see the chat is very, very active. And as a young global surgeon, it's so exciting to see that even during these discussions, there's already work going on in the chat, and people are already collaborating, partnerships are forming, and everybody wants to help and go forward. Our hope is that today is one of the many events to come that really highlights the need for surgical system strengthening in Lmics, and we'll continue to push forward this agenda. With that, I would like to move on to some questions to get us started. Sarah, can we get some questions?
Yes, most certainly. So let's see, I had noticed that Emmanuel back earlier on in the session had posed a question, and I want to make sure that we don't forget it. So he states that some key stakeholders that we must include or involve are the patients, caregivers, and community-based civil society. How can we mobilize these and leverage their support, including their political voice and power, to lobby for more investments and prioritization of surgical care improvement at the local level? Let's see, would someone like to take that question?
Yeah, that's a good question from Emmanuel, because certainly multilateral partners also want to see that there's been a comprehensive engagement. And so they want to also know that the community has been involved, CSOs have been involved, and as Kees alluded to in our stakeholders meeting, we ensured that they were there as part of the meeting. We also have to realize again that CSOs sometimes they can be picky on what stakeholder meetings they want to come to. So certainly when they see that it's a high-level meeting, it is a meeting where the high echelons of the Ministry of Health are inviting them. They're very keen to come. They're very keen to participate. I don't know if it's a Fiji thing, but that's what I seem to see. So it will be important to be able to get the high echelons to make the invitations and get the CSOs to come along. And then when you do then talk to the multilateral partners, you can actually say, look, we've had a truly comprehensive stakeholder discussion on what needs to be done. And the CSOs and the community have been involved. And who are the community? The community are different from each country and its geographical place in the world. In some countries, in the Pacific, for example, faith-based organizations, churches are very important. So when you say community, that must include the faith-based leaders. In other areas, there could be the traditional leaders that are important. The voice of the community. So again, I suggest that when we talk about community, doesn't necessarily mean we cut and paste the attendees list from a different country and bring it to your own country. But you must see who is relevant. And as I've said, for example, in the Pacific, a very big part of the community is actually the faith-based organizations. So they have to be involved because they do represent a significant portion of the population, if not maybe up to 70% of the population in some areas. Thank you.
Fantastic. Thank you so much, Minister. Okay. Just trying to keep track of the chat here in our Q&A box. See, Keith has brought up, as Key mentioned, a variety of fantastic comments here during our session. And I'll just read off a couple here that are open in the Q&A chat. One is that we need to partner with public health and CD organizations and nurses to present a strong value proposition to governments to invest in the SOTA ecosystem. And I think that's very much in league with what many of our speakers have contributed to the conversation today, just coming from a very, very, very comprehensive standpoint. And secondly, visuals that move people emotionally are powerful agents for moving the public and political actors. Data alone will really move decision makers. I think that's definitely true as well.
I had a question, so as I was listening, and Minister Wanka did point out about the faith-based organization and the different stakeholders. And since you're talking about stakeholders, every stakeholder has something important and something that they want to propagate. And as Minister Vanka also talked about, how we should have a surgical narrative for everything in every discussion. So how do we find these important things for different stakeholders, and how do we approach these different stakeholders? Do we need a list for each and every stakeholder? Like for faith-based institutions, we'll have different approaches, and for ministries and political institution, we'll have different approaches. Like, how do we approach each section? Yes, Dr. McLeod, please go ahead.
I'll have a start off on that, Shunik. I think that for SOTA Care, the narrative hooks are pretty much the same. So, you know, the story that we're creating is around the patient, and whether that's a child with a congenital abnormality or a young adult who's come off their motorbike and had trauma. You know, people will respond to an emotional hook in the story, and that's probably comes across the board. But then that narrative needs to be tailored to the person that you're looking to engage, or the civil society organisation that you're looking to engage, or the donor that you're wanting to engage. So playing to their specific kind of targeting, and Keys mentioned CUGH being happy to look at infrastructure development, whereas USAID may not be. But it's I think that's so knowing the particular interests or strength of a potential donor is really important. But the framing can start in the same way, but then also probably needs to be channeled. For example, DFAT, the Australian Department of Foreign Affairs and Trade, that deals with our overseas development assistance, is now very focused on security. And you know, we could talk forever about the securitization of aid and what a global phenomenon that is becoming, but the narrative for DFAT now can be around, since the last white paper on ODA assistance, which is now very out of date, but we can structure the narrative that we create around health security, because suddenly security is paramount. And if we talk in terms of security and how robust health systems contribute to security on every level, not just individual human security, but national security as well, then that I think can be a successful strategy. I'll stop there.
That's fantastic. Thank you so much, Dr. McLeod. We also have a question from Abby in the Q&A section. What are some of the key characteristics or features of high-income country and low-middle-income country partnerships that are in place that allow these collaborations to generate the most positive impact in LMICs?
Yeah, I could probably start there. We've had a very strong relationship with the Australian College of Surgeons, which includes surgeons of both countries, Australia and New Zealand. Australasian means Australia, New Zealand, does not necessarily just mean Australia. But anyway, that collaboration has also included the support through the Australian government funding through DFAT. And so DFAT, through the Australian College of Surgeons, it's a funding stream to support Pacific Island countries. It's called a Pacific Island Project for Papua New Guinea, and a separate one for Timor-Leste. And the funding stream helps Pacific Island countries in terms of initially surgical visits for secondary and tertiary level care that was not able to be done locally. And over the last 20 years in Fiji, that is actually developed into also into a mentoring process. So some of us were mentored through that process, and also included the skills transfer, and finally the ability to do the majority of those operations locally in Fiji. And so we talked about with Rex how we wanted the super surgeon from Rex to become finally redundant in the case of the ability of the local surgeon to be able to do the cases locally, and they providing mentoring not necessarily in-house, but also from off-site from Australia, and that's happening. So that's a very good example of how a low middle income country and a high middle income country can actually work together. The other thing to understand is what's been very helpful though is that over the last 4 or 5 years, Fiji and Australia have also, on a political level, developed a very strong agreement. So we call it the Rwanda relationship. So under that umbrella agreement, everything else underneath, so for example, under that umbrella agreement, we can talk to DFAT, like just pick up the phone and call the High Commissioner, can call and say, look, we need something here. Would you have some funding to buy a diathermy machine? We just need a diathermy machine. There's a hospital, district hospital that needs some work. Australia did some work there about 20 years ago. So again, that political will is very important, because that umbrella agreement, because before the links that we had with the Royal Australian College of Surgeons were essentially links between friends, and then one friend had the ability to be able to garnish funding support, and this friend had a need, and we said, look, we'll work together on this vision. But now it's we are surfing on that big wave of the political agreement that now is in place between Fiji and Australia. So when they had some bushfires in Australia, we had some Fijian soldiers that went across, helping the bushfires. We have also young people who are going across to work on the farms and rugby and sports. So it has come also under this agreement. So you can see that you can do it on a organization to organization level. You can do it on a personal level. But then when these champions, retire, then what goes on after that? You need to develop the sustainability. And the sustainability will be the sustainability of those relationships can only happen if you develop the institutional agreements, and having the political will again helps, because having that agreement at a high level means that whether I am here and Liz is there, or whether I'm not here and Liz is not there, it will continue. And that's what Liz and I really want, is that it's not dependent on the person, but it's dependent on the fact that we develop a framework of an agreement, and that is long lasting.
That's very well put, Minister Wonka. Liz, I saw that your hand was raised.
I just wanted to add to what the Minister said about the Pacific Islands program, which is really, I don't have experience in many parts of the world, but in the Pacific, that project's been running for almost 30 years now. And one part of the question, I think, Sarah, was that what are the key characteristics? And Minister Wanga has talked about relationships, but it's really this project has been so successful because of a deep mutual respect and relationships that have been built over many years. And now to sustain that, we need to be having movement of our young people, of our trainees between jurisdictions, and continuing to build those relationships as we go into the future. So basically, the success of programs like the RAPS and the Pacific program is based on deep respect and listening. And I think another really important aspect is that it's been generated by clinicians with patients at the center of the programs. So we come back to, you know, why do we do what we do? And it's because of the patients. That's who we're serving. And so if we keep some focus on the patients, then we have projects with good outcomes. Thanks.
So I love where this conversation is headed, and that was triggered by the question from Abby, right, about this sort of a collaboration and between high income and low income countries. You know, like I go back to the quote that Mark used. You know, there's abundance of money in the world, but people just don't want to share. When they do share, sometimes it's in the spirit of charity, and I think we need to move from this charity mindset to solidarity mindset, where for me, solidarity really means equal footing. Power is shared and decision-making is shared, right? We're all in it together. And I think this is where it's headed. And like Liz has said, you know, when we focus on a common enemy, a disease, or the patient themselves that we need to help, then we become teammates rather than, you know, another country that we need to help out of sense of charity. I think this is a problem that we tackle as teams. And then I just want to touch a little bit on the siloing. You know, we do have, whenever we have these global surgery conferences, it's the echo chamber, right? You know, we have our usual suspects. And you know, we had an event, I think it was 3 years ago when we had it in Geneva, where the NCD community reached out to us, the surgical community, because their commission looked at the NCD burden for the poorest 1 billion. And they saw that the treatment of NCDs, diagnosis, things like cancer, strokes, diabetes, all these things cannot be treated without surgical care. So they were dealing with conditions. We have the intervention, so we have to pair up. And as someone, I think Keith had mentioned, whether it's the injury community, the NCD community, we have the solutions for some of their problems, and it makes so much sense to partner with them and co-advocate, and maybe even do some implementation that's, you know, like for instance, cervical cancer. That's a hot topic right now, and they need surgical care to not only initially after diagnosis to treat these cervical cancer cases. So I think it's an important thing to partner, not just among ourselves, but also beyond the usual surgeons lounge crowd. Over.
Thank you so much. It's so hard to summarize everything because we have talked about so many different topics, but these kind of events actually gives us hope and make surgery less of a neglected child. And for that, we have to continue these talks. There should be more talks on financing and sustainability. And that's where we are headed to. So stay tuned for the next session. And for now, thank you to the audience and thank you all to the panelists.
Thank you so much to our panelists. Thank you to Sarah and Shrinek for your moderation. Just a wonderful panel about how we can all really work together. I really liked the concept of not charity care, not charity, but solidarity. So I really think that's really important for this. So let's move on to our third session. Our third session today we'll be talking about sustainability for effective SOTA care. We have a wonderful panel today. I want to introduce our moderator, Dr. Adrian Gelb. Dr. Adrian Gelb is a professor at the University of California, San Francisco. He's currently the president of the World Federation of Societies of Anesthesia. Without further ado, Dr. Gelb.
Thank you very much, Terry, and thank you for those who've joined us for this really exciting couple of hours of discussion. We're going to pick up on some themes that were deliberately discussed and others inadvertently mentioned along the way. And I do want to thank the Honorable Minister for mentioning the importance of sustainability, because that's what we want to focus on. Although we're going to broaden the scope somewhat from the scope we've been talking about. As global healthcare leaders, we play an important role in driving the transformation of SOTA Care into a model of social and environmental responsibility that meets the needs of the communities we serve. And this session is going to bring together leaders from across the surgical community to discuss how we as healthcare practitioners can identify, integrate, implement sustainable environmental, workforce, economic, and societal practices. And we're going to start on the environmental side. Our first speaker is Dr. Jody Sherman. Jody is an associate professor of anesthesiologist at Yale, and she's also the director of the Yale program on healthcare environmental sustainability. Jody is going to speak about principles of environmentally sustainable SOTA care. Jody.
Sorry, had to figure out how to unmute. Thank you very much, Dr. Gill, for this opportunity, and to all the conference organizers. I've been invited to present specifically on the principles of environmentally sustainable SOTA care. And what I'll do is start with some background of why this matters, and then get to the principles. So why this matters in healthcare. Pollution is a leading cause of morbidity and mortality, globally responsible for about 16% premature deaths annually. Ironically, healthcare is a leading emitter of pollutants against our mission to first do no harm. Reducing healthcare pollution is an opportunity to improve the triple bottom line of the best care for the most patients at the least cost, and importantly, engaging health professionals around healthcare pollution prevention is a key for public policy and societal transformation. So globally, we know that healthcare is responsible for nearly 5% of total global greenhouse gas emissions, and it's rising. Healthcare is an enormous part of our economy, 10% of the global economy. So if we can transition this economy, it will have ripple effects throughout all of the economy. Have to talk about the United States. We're an outlier here, and not in a good way. Per capita healthcare greenhouse gas emissions. This is per capita expenditures on healthcare on the x-axis, and y is the greenhouse gas emissions. The US is an outlier. We have the highest per capita healthcare greenhouse gas emissions in the world. 0.25% of these global emissions are from the US, even though we're only 4% of the population. China has the highest absolute value, however, and it's rising, however, per capita, it's the US. So now if we have the best healthcare outcomes for that, maybe there's some justification, but we don't. So if you look at the greenhouse gas emissions per capita on the x-axis, on the y-axis is the IHME's Healthcare Access and Quality Index. So high is good on y, low is good on x. So again, the US is an outlier. If we had the highest health system performance, there might be some justification, but we don't. We see it's possible to have lower emissions. In fact, after around 450 kilograms of CO2 equivalents per capita, there's no real benefit in having higher healthcare emissions. So the good news is that there is opportunity to improve healthcare access and quality while mitigating those emissions. And there is opportunity. We know 1/4 of global healthcare services are deemed inappropriate and low value, and this applies to both high and low income countries, and then half the world lacks access to essential services. So there is opportunity here to have more resource to go around and less pollution. And so it's important to understand what those relative emissions are. On the left is a diagram from the National Health Service in England, but this applies to several other health systems. And importantly, we'll see where those relative emissions are coming from. This is on a life cycle basis, so both manufacturing, transportation, utilization, as well as disposal. And on average, 4/5 of these emissions come from the supply chain, notably pharmaceuticals and chemicals, medical devices and supplies, and food. So this tells us where to focus our activities, and important is where the levers. So healthcare administrators, clinicians, regulators, we control the consumption of resources, appropriate or inappropriate. In manufacturers, regulators, they control what's embedded in the products and services that we use, what goes to marketplace. So it tells us where our levers of action are. And really the highest question is, what is beyond what's best practice for patients, but what's also best practice for our workforce and public health? And so together with the World Federation of Societies of Anesthesiologists, we did a Delphi survey of global experts. It was a relatively small survey, but what was really interesting is that the results apply to any specialty. So I might slip in the word anesthesia in there, but it really applies to all of SOTA. And the foundations include that patient safety should not be compromised by the introduction of sustainable practice. High, middle, and low-income countries should support each other in appropriately delivering what is green healthcare. There are lessons and exemplars in all income brackets. And healthcare systems should, apologies, Adrian, be obliged to reduce their contribution in global. There should be some mandate and requirement. We should be leading this initiative. The first principle, minimize the environmental impact of one's personal clinical practice. Healthcare makes significant contribution to pollution and climate change. So safe and high quality alternatives exist. In the case of my specialty, inhalational drugs can be substituted by total intravenous anesthesia and regional techniques where it's safe to do so and it's affordable to do so. And importantly, each one of us can make a difference as a clinician. The second principle is to use environmentally preferable equipment and medications when it's safe to do so. This again, applies to not only anesthetics, but to any drugs, any devices we use in healthcare. There's a lot of information in my particular specialty, but it's not exclusive to it. Importantly, minimize the overuse and waste of medications, equipment, energy, and water. Operating theaters in particular generate about 1/4 of hospital waste when we're just talking about acute care facilities, 1/4 of that coming just from my specialty. Single-use equipment is on the rise and often lacking evidence of benefit over reusables. Sometimes it may be true for things that are difficult to clean and very cheap, small IV tubing catheters. Obviously, we're not going to reuse those, but by and large, this trend towards single-use disposal devices is problematic. Its benefit is unsubstantiated. It leaves our supply chains vulnerable to interruption, as we've seen with the COVID pandemic. And a lot of the risks and vulnerabilities are the same, whether it's COVID or climate change. And so ultimately, we should apply the 5 Rs, starting with reduce, reuse, reprocess, recycle, rethink, and research. And the bottom on the right is from Jane Goodall, but the principles are the same. Have to start by mitigating inappropriate use of resource up front. Fourth, incorporate environmental sustainability principles within our formal education. It's gaining recognition as a curriculum competency, both in undergraduate and postgraduate training. There's a question of who trains the trainers. Somebody has to start. We all started without knowing anything. So we have to educate ourselves and become the teachers. And we need to include sustainable practices in our continuing professional development resources, conferences, and meetings. It's on us. We started without knowing anything. Fifth, we need to embed sustainability principles within research and quality efforts. There's nothing more to say about that. This really is about research and quality. And can be embedded into every single aspect of the agenda. 6, we need to lead with environmental sustainability activities in our own organizations. We need to be examples. We need to move beyond our personal practice to our departmental and healthcare organizational practices, our professional societies. There is opportunity for us to be agents of change at every single level. And the last principle is to collaborate with industry to improve environmental sustainability. Every single thing that we use, every medical device, every drug, any innovation has come with collaboration with clinicians and industry to improve healthcare safety and quality. And we have to get involved and push the sustainability agenda. And we should insist that industry is transparent, about the environmental footprints of their products. And there is a lot of work to address that on the regulatory front. But we need to ask for it. And then finally, I just want to put forth, there are things, obviously not a lot, not covered in 12 minutes, but we do have this planetary healthcare framework and the three main themes, and this includes stuff we have and have not talked about. Reducing emissions embodied within the services that we provide. That includes shifting to clean energy. It doesn't help to electrify if we don't have clean energy, but we need to do both together. Have sustainable, renewable, consistent, resilient sources for energy. We need a more circular economy. That means not having a take, make, waste and throw things away, but keep things reusable and in circulation materials. We need a culture of resource stewardship. We also need to match supply with demand. That means addressing inappropriate care, both too little care and too much. And too little care also increases demands and inappropriate use later on. So both those have to be addressed. And finally, moving upstream to reduce the need for healthcare. And to begin with, that means health promotion, disease prevention, and addressing the social determinants of health. When we think about what high value care is, we need to include the sustainability and social agendas. And my talk is focused on the environmental piece. But that is the best outcomes for the most patients at the least cost, but also the least environmental harm and the least social harm. And with that, I will say thank you.
Great. Thank you, Jody, for, I suspect, dropping a bomb on many of us about our practices, which was the intention. I'd remind the audience, put your questions in the Q&A and other chat in the chat. There are, I think, clearly lots of implications on environmental waste. There are lots of things that high-income countries can learn from lower resource settings on reusability. And there's obviously the whole issue of dumping our junk on other nations and telling them that it's good for them. We're going to move on to the next presentation, which will be given by Dr. Bisola Onajen-Obembe. Bisola is on the faculty at the University of Port Harcourt, Nigeria. She's also on the G4 board and the WFSA board. And she's going to be speaking to us about creating a sustainable and effective workforce. Bisola.
Thank you very much, Adrian, for that introduction. And I will be speaking on creating a sustainable and effective workforce. I know that I may be preaching to the choir. So we know about the surgical workforce, surgical specialties, anesthesia, anesthesiologists, as some will call it, and OBGYs. And in low and middle income areas, specifically Africa and Southeast Asia, we have 1/3 of the world, population of the world living there. And we have only 12% of the specialist surgical workforce in that area, in that region. And we know that the SAO ratio that is ideal to reduce morbidity and mortality is 20. So we need 20 SAO ratio, 20 per 100,000 population. And the anesthesia workforce map shows also that the sub-Saharan region, as well as Southeast Asia, has a crisis of anesthesia providers and anesthesia specialists. So here we see less than 1 per 100,000 population. So we now know that we need 4 specialist anesthetists per 100,000 population to be able to achieve reasonable standard of health care. And the figures are so embarrassing. When you look at low and middle income areas, you find places like Zimbabwe, Nigeria, Tanzania, for example, Sierra Leone, less than 1 anesthesiologist per 100,000 population. This is very, very serious and shows that we actually need 300,000 additional anesthesiologists by 2030. So what do? The best way to predict our future is to create it. And that's why we're talking about creating a sustainable workforce. And Dr. Jim Yong Kim, the former president of the World Bank, said that, and I quote, "Unless you invest in people, you are not going to see growth in the long term, the medium term, and maybe even the short term." So it's really important that we train people. But where are these people? Sometimes we say there is nobody, we don't have anybody, but we have human resources. Look at Africa, for example, now. We have a large growing population of young people, less than 25 years old. They form the main population. And between the working population by 2040 will be between 15 to 64 years old. We have over 1.something billion, 1,200 million people. So we have people in Africa, people in Asia, people in China. We have the population, but there's something that we are probably not tapping from that immense wealth of population. So for a sustainable workforce, we have to be careful because we don't want to take the easy way out. And the law of the 5th discipline says any long-term solution must strengthen the ability of the system to shoulder its own burden. It also says that small changes can produce big results, and the area of highest leverage are often the least obvious. So for that effective and sustainable workforce, what do we need? It's important that we must have a plan, the ENSOP, deliberately planned for the community and country. We must realize that countries differ, they are all different, and there is no one solution that will fit every country. So we can't come with a formula and say this is the answer. It's important to know that we need to grow through learning. We have to learn, we have to, and through a reflective process. Workforce cannot be built in a day. It takes a whole planned, serious, taking step by step, serious steps, taking and keep on the momentum. So training is key. And in the earlier speakers in the first session says action, research, implementation. So it's not about having that plan, but following through with implementation and action, research. So we have the National Surgical Obstetric Anesthesia Plan, but we must be able to follow through. And what is action research? So you have the context and the purpose of every country, of each state, each country, or a community, or a place. And you have that, you've constructed, what you have, what is the context, and then the planning action, the plans to take. And then we now have to take the action. And taking the action is carrying it out and then evaluating. So it's not a straightforward process because you keep starting from the beginning again and keep going around in circles to make sure that you're making progress at each circle. So it's not one process. You keep reviewing what you have done, we keep taking the action, we keep evaluating, and then reframing the process. We started with a snapshot of quantitative numerical data on workforce that has been analyzed in relation to the national and state population. That is the NSOP. Then we need to look at the in-depth, take an in-depth insight to the major dynamic factors that contribute to the workforce gap. And this is different in different areas. For some low and middle income areas now, LMICs, you find out that we have a problem with brain drain. We train the workforce and they all go to greener pastures. So there's a factor associated with training. Are we going to train them and keep them? Factors associated with professional profile. I saw in the chat when we talked about anesthesiologists, making anesthesia more sexy. Well, whatever that means, the profile has to improve. And then factors associated with geographical location. Why is it that some specialists want to work in urban areas, you know, and avoid the rural areas? So it's important to have a strategic conversation around the workforce, around the strategies we need to take, and then to have that buy-in from stakeholders and participants and actors in an action research. This is very important. And the earlier speakers mentioned something about political will. So we need to make sure that we are at the table and we are part of the discussion concerning workforce development and the sustainable workforce. It's important that while we want workforce to be sustainable, it's not okay to rely on our HICs, high income countries alone. We need to work together and have what we call a learning organization so that we don't wait. It's not a situation where we are helpless and we wait for a savior to come and help us. So we're creating a learning organization and allowing transformational leaders to emerge. We need to establish an autonomic, locally run departments, divisions, units, hospitals. It has to be locally run, and it has to be, we need to have a teaching, to teach hands-on in the workplace. And of course, turn all our centers to not just service alone, but training centers. And we must be able to replicate the action research. So in order for transformation to occur, we need what we call a triple loop learning how to learn, not just a framework where you have the actions and the results, but you need to be able to reframe as well as change our perceptions if possible, and look at the context again, look at the framework again, and then take other actions and results so that we are learning from what has gone, from what we're doing and making it better. That is how we can sustain our workforce. The general recommendations will include recruiting, nurturing, training, and retraining. But then this is not enough, because if we don't give an incentive for learning and training, and the sustainable workforce will not be there. So incentives has to match what we expect from a workforce. Logistics support is important for our workforce to have logistic support, everything we need to make progress and to grow. And it's important also to have a selection strategy. Who are the people that will stay and will grow? Who are the people that are passionate and will invest in the effective, sustainable workforce? Leadership is very important. Everyone, wherever you are, at what level, whether it's the primary, secondary, tertiary, it has to be driven by leadership. So we need to talk about leadership during leadership seminars, as well as promote diversity, equity, and inclusion in our workplaces. It's important to have very strong institutions and partnership. We mentioned earlier, one of the speakers talked about partnerships, how HICs and LMICs can partner. So to have an effective, sustainable workforce, There must be strong institutions. It has to be driven by strong institutions, because we need to have postgraduate programs and accreditation of these programs, policy making. We've said it not once, not twice, on global surgery and anesthesia. We have to participate and be at the table. Organization of work-based leadership seminars and mentoring programs, and consultation and assisting with the establishment of training programs. This is has been known to help improve the workforce. And then facilitating, setting up, scaling of units and divisions, scaling up of units and divisions and departments. These are very important. The WFSA is noted for working with national societies and with all the anesthesiologists all over the world. Imagine a membership society of 136 in different parts of the world, working together to enhance anesthesia practice. So this is one of the very strong institutions that has helped in training and retraining. Another strong institution, I'm going to give an example from my region, is the West African College of Surgeons. And this, you can see, has just not surgical specialties, but also a faculty of anesthesia. And this has helped to sustain training. Yes, we need to do more. We need to look at the triple loop and see what we can improve in the West African College of Surgeons to enhance the workforce. Another strong institution in my country is the National Postgraduate Medical College of Nigeria. And this also has all the faculties from the medical faculties and surgical related faculties that has helped to improve and train, certify the workforce in my region. I'll give you an example from an East African country, Rwanda. And this is the University of Global Health Equity. It's a university that will advance global health delivery by training new generations of global health leaders who are equipped in not just building, but sustaining effective and equitable health systems. And of course, we've talked about Dr. Paul Farmer and the partners in health. And this has been very, very useful and effective in over 10 different countries. And thanks to this partnership in health, there's been an advancement in the workforce around many LMICs. Leadership, like I said, is important, and it's not just one type of leadership. Most of these institutions have this leadership in common. They are strategic, they are transformational, they're integrative. You could see SOTA, surgery, obstetric, trauma, anesthesia, and other surgical specialties. They think of systems, system thinking, and global leadership. And I added spiritual here because, we're very prayerful nations in LMICs, and you cannot do without the guidance of divine guidance in many of our activities. So learning is a key thing. And in order to have a sustainable workforce, we must be able to learn from our learning organizations as a team. It's known that learning is best. The brain learns best when there's attention and motivation, and when it's exciting and meaningful, and when there's a sense of community, the contact urge. So this has helped many workforce in different communities and countries to be sustainable, because there's that contact urge, there's that community, and it plays a critical role in learning. And then the other key elements optimal mind and brain learning is an atmosphere of relaxation, relaxed alertness, when you don't feel threatened, when you're motivated by your team, and when you have your hands-on experience, then the learning becomes easy and effective. orchestrated immersion in complex experience. And this comes with being on call, learning in the workplace, having your hands on whether it's surgery and meaningful anesthesia practice and active processing of the experience. So it's not just one experience or someone comes and gives you, these are the goals and these are the objectives and this is what the framework is all about, but you actually involve reflecting, processing the experience and thinking it through, and the workforce is able to learn and say, yes, we have made, we're improving. So in conclusion, a sustainable and effective workforce is possible. It has to be driven by strong organizations, institutions, ownership, country ownership. The countries must take ownership of their surgical and anesthesia workforce training and development. So it's this is possible, and this has to be brain-based to be sustainable and to be effective. Thank you.
Thank you very much, Bisola. And a reminder to the attendees to put their questions in the Q&A or comments. Similarly, we're going to hand the microphone back to the Honorable Minister of Health for Fiji, Minister Wankambeti, and he's going to tell us about surgical sustainability in Fiji. Wonka,
thank you,
microphone's yours.
Yes, thanks, Adrian. And I'd like to thank the two previous speakers for their contributions, because they've effectively talked about what needs to happen, first from a global perspective, and also what needs to happen for sustainability from a more comprehensive perspective. What I'd like to do is actually talk about what we have been doing in Fiji, and I hope that this will be helpful for today's discussions. We have come a long way in the last 20 years. 20 years may seem like a small span of space, but it's been very significant here in Fiji. About 20 years ago, I was a trainee. More than 90% of the workforce, the surgical workforce, were expatriates. And we had about 4 qualified local surgeons. And again, we had those that came back from Australia, New Zealand, and in other places where they did training and came and worked for a few years, and then resigned and left for a whole lot of reasons. One of them obviously was the conditions of work. And many developments have happened since then in our workforce and advancement of surgical care in Fiji to cover all parts of universal health coverage, including primary, secondary, and even tertiary level care. And I had alluded to this in the previous panel discussion. So let me talk about very quickly the 8 things that we have done. One is certainly the surgical postgraduate training. This is very important, the access to surgical postgraduate training. And I'd like to suggest and also encourage every low middle income countries to ensure that they have access to surgical training, whether it be local training or whether it be training in a country close to home where you have access. What we found is once we started doing our own surgical training, beginning in 1998, well, we have graduated 40 specialists for the Pacific, and 30 of them are Fiji specialists. Now, those 30 Fiji specialists that have graduated through the training have had the ability to also then have an opportunity to spend anywhere between 1 to 4 years or 5 years in Australia and New Zealand for further training. Some of them have challenged the fellowship exam in Australia and have continued to live there, whilst 1 or 2 have come back and worked in Fiji. So the first important thing in regards to sustainability is actually having postgraduate training or access to postgraduate training. Secondly, is that we found one of the barriers also was that the way the Ministry of Health structure was positions were based on an establishment. So you had an establishment, for example, you could only have 5 qualified surgeons and 6 registers. What we did was we worked with the Ministry of Health and Government and worked to provide a career structure where we had more positions. And we always talk about the pyramidal structure, so it's actually opening it up so that we have more positions for consultants at the top and those who are junior consultants. And having that more senior positions lures the young surgeon to stay, to understanding that they have an equal opportunity to move up the chain as quickly as they can. When I became a consultant in Fiji, and a specialist and a consultant in Fiji, I was the youngest at that time. It was about in my early 30s. It was unbeknown to be a consultant in Fiji when you were about 33, because at that time it was you had to at least be over 40 to become a specialist and a consultant because of the way the pyramidal structure was. So it is important to ensure that you develop establishment, you have positions at the tops, because once you keep on training, then they have to have a place to go into, and that helps with sustainability. The other important thing, and this is something that we haven't discussed, I haven't heard this discussed a lot, is that you need to ensure that surgeons are remunerated well. This hasn't been talked about in detail in a lot of discussions on safe and affordable surgery, but surgeons need to be remunerated well. And one of the reasons why I joined politics and I joined this government was back in 2016, they listened and they increased the salaries of doctors, and surgeons' salaries increased by twofold, by double their salaries. And by doubling the salaries of surgeons, we've been able to retain surgeons. And I think this is an important component of sustainability for surgery, obstetrics, and anesthesia. We need to ensure that they are remunerated well. And again, I bring it to the fore, is that this is something that we haven't talked about a lot in global circles about how we can have sustainability, how can we grow access to universal surgical care. But one important part is the people that actually do surgery, do obstetrics, do anesthesia, and how do we retain them? And one important part of the retainment is their remuneration. And we now have a reverse movement. So before we had surgeons moving out of Fiji, from Fiji to other places, moving out of the public sector into private sector. Now we have doctors coming back into the public sector because the remuneration is actually better. So that's number 3. Number 4 is we also have to understand that as surgeons develop, they will develop subspecialization, and we have to strike the right balance between understanding what the limits are for the countries, a low middle income country, the resources that we have, but our ability also to support them in the subspecialization. And that is really important. For example, you may have a surgeon who really just want to do laparoscopic work. And so how can we support him sustainably, but also ensuring that he grows in his subspecialization. That we found has been one of the reasons why people have chosen to stay, is because we can support them in the areas of subspecialization. Better surgical infrastructure. Over the last 10 years, we've really pushed a lot of resources into our operating theaters and intensive care, post-anesthetic recovery units, OT refurbishment, imaging. Recently, we've had some of our district hospitals have been renovated, including making sure that we have new state-of-the-art theaters and state-of-the-art for in low middle income countries such as ours. So, pouring money into this surgical infrastructure. 6, and again, very importantly, is the support staff. So nursing and support staff development. So, we initially went with the surgeons pushing with their training, with our surgeons pushing with our training, pushing with really, I would say now in retrospect, it was actually quite selfish because we were pushing us forward without thinking about the support structure. And then we woke up one day and said, look, we need the pathologist to come along on this ride, we need the radiologists, we need, everyone. So, the anesthetic attendants, even the orderlies in CSSDs that actually sterilize the equipment. So this is where we really went back and said, look, let's really support the support staff development and also the support structure development. Number 7 is partner support, and I've talked about this before in the previous panel. We need to ensure that we continue to pick on the support of partners for the long term, for the sustainable plan. Now, why I'm saying this is because with low middle income countries, your budget priorities may change a little bit, may pivot a little bit with your budget priorities year to year. But the partner support will be able to help you to sustain some of the programs that you are beginning or you are initiating. So, for example, we're really pushing for access to safe and affordable surgery. So, but we also understand that the finance needed in this is actually more than what we've allocated within the Ministry of Health. And so that's where the partner support. That's why Key, the previous panel, talked about how we are talking with USA about how they can be able to support us in some of the areas. We're actually working with CUGH in the hope that they will help us with the renovations of our rehabilitation hospital, and actually putting in operating theaters to be able to deal with rehab operations in the rehabilitation hospital rather than at the main hospital. So it is important to be able to work with the partners in these areas. And lastly, is the being able also, again, looking back at the remuneration of doctors. What we've also done for the surgeons is to actually give them a salary increase so that they have actually earning 2 times more than they used to earn before. And we've also said you can have private practice. And these are the rules of engagement of the private practice. And the surgeons love it. They love it because it is, not only is it, being able to add to their income, but more importantly, it is a different practice. They go to an environment that allows them to practice, separately and differently from the public practice, and it's a change of scenery for them. And we found that has been, something that has also been very helpful in our sustainability for our surgical workforce. Thank you.
Thank you very much for that very insightful presentation, Wonka. I'm sure there are lots of opinions, comments, and perhaps recommendations on incentives. I did put in one comment that it's more than just money that is important. And in relation to fellowships, I just point out that the WFSA does support some 40 or so fellowships, sending young anesthesiologists to specialist centers in their geographic region. So it's reassuring for us to hear somebody like yourself talk about the importance of that. We have one more presentation, and that's from Dr. Terry Reynolds. Terry leads the Clinical Service and Systems Unit in the Department of Integrated Health Services at the World Health Organization. And if you wonder what exactly that means, she brings together the following services: primary care, emergency care, operative care, critical care, and palliative care in an integrated fashion. And Terry is going to be speaking about creating a sustainable continuum of care WHO's Integration of Clinical Services and Global Health Action Plan. Terry.
Thanks very much, Adrian. And please just let me know if you can't see the screen or if there's any problem with the sound. But it's a huge pleasure to be here and to see so many familiar faces and friends, colleagues and partners. I'm going to go through very quickly a few things because we don't have a lot of time and most of it's already been said. But I wanted to focus frame it in terms of what I think of as some key principles for sustainability. So things that can really make your agenda and your goals really embed within a sustainable health strategy. So the first of those is to make your problem a solution. And what I mean by that is we've had a number of resolutions over the years that underlie WHO's work in this area. And it started in 2007 with something largely framed around injury, even though it was called emergency care systems, and then went on to look at resilience and disaster management as an important frame, and then finally surgical care explicitly. And then after that, the sort of continuum of care, sort of emergency care systems from the moment something happens all the way through acute services like surgical care and anesthesia care and critical care, and going all the way through to rehabilitation. So what I mean by be a solution is a lot of people, the ministers that you speak to and the ministers on this call can speak to this. You have a lot of agendas, these resolutions and these sustainable development goals. They're things that have already been accepted as a mandate and as a goal. So a lot of people will think of the kinds of services you're talking about today as only addressing these sustainable development goal targets. But in fact, the same investment that you make in this platform, the continuum of emergency, critical, and operative services give all of this benefit. And so that's why I say make your problem a solution. Don't walk into a policymaker's office and say, hey, I have another problem for you, something else you need to focus on. You can walk in with this group of services and say, hey, I have a solution for you. This next one is very related. You want to be of use, but you want to be of use for the problem at hand. So you don't have to walk into these conversations trying to get the person you're talking to come around to your point of view. What you can do, if you're in a very powerful dominant narrative, like we have been for the last couple of years, like COVID, that is the problem that people have been trying to solve. There are ways to frame your solution within that. So you want to be of use, but you want to be of use for the problem at hand. And that means understanding how to communicate to people what is happening to the surgical burden and the need for operative care around the world, which is that there is an increasing backlog that we are going to struggle to ever overcome in many countries. So the frame for that is this maintaining essential health services. There are strategic shifts that countries have signed up to in order to maintain essential health services in the pandemic context. Each of these is a mechanism for strengthening emergency, critical, and operative care. Again, another master narrative, so to speak, primary care and a PHC approach. That doesn't mean only primary care at the exclusion of hospital services. What it means is organizing, framing all of your services that people need through the life course relative to primary care, putting primary care as the center of gravity. So it's very easy to communicate that we want everyone to have primary care all the time. We hope that their need for emergency, critical, and operative care will be exceptional, but it is inevitable across the life course. So what you want is the center of gravity in primary care, but primary care that is supported by emergency, critical, and operative services. Those are different ways of being of use for the problem at hand, framing your goals within this master narrative. And those change over time. Another key principle for this is what has already been spoken to much more articulately by Bizola, which is you need to make yourself useless. You need the health workforce to be sustainable. So these are all WHO normative products. What we're doing right now is transforming them into innovative training modules, the innovative training platform, and in partnership with many of you on this call. The goal is really to not just insist on the importance of that knowledge, but to make sure that it is getting where it needs to be and making sure that it doesn't stay with you, that it's going out to where it needs to be. And that if you have no idea of who can replace you, and if you have no idea of how you're going to be useless, then you are making a mistake. Then you're not doing your job. So you should feel less and less important every single day if you are doing your job right. Then pay attention to where you are. It's going to be a hard sell if you are trying to get people to add an activity to what they are already doing. By paying attention to where people are and what is happening around you, you can have great success. And it's another form of proposing a solution. So countries around the world right now are creating packages of essential health services for universal health coverage. They may not be thinking that surgical care, emergency care, anesthesia care is about UHC, but they are building packages. And so we have a tool that is the UHC compendium of interventions for universal health coverage, and it helps countries build these packages. So one thing that's very important is to have the essential surgeries and anesthesia services, trauma care services, obstetric services within this tool, so that when countries build UHC, they can see how these services are needed to achieve universal health coverage. And this is what happens then. Then you get packages, even when they're very, very simple packages of surgical services, then the platform is there and it's something to build on. It's a foundation. And once these services are in packages of services for UHC, then it's used as a foundation for so many different aspects. And I won't spend a lot of time on that now, but please believe me that this idea of the national package of essential health services is one of the most powerful and sustainable health system building mechanisms that exist today. Make things and count things. You also need to make things for people. You can't just sort of tell people that things are important. You need to make things that can be used, that can be in hand. We need to simultaneously act at very high and powerful policy levels, and at the exact same time, build the tools that are needed to make things work. So this is a set of tools designed around implementing national service packages. And this is really kind of in a middle level. And it supports the impact. It delivers the impact of the high-level policy work we do with countries to build packages. And then we also make little things. So we've, in about 40 countries, now about 45 actually, we've done these system assessments to help countries. They're not really assessments, they're priority setting. They specifically help countries not create a separate plan, but identify their priorities within these areas for their national health strategies. And the output is a set of country relevant concrete actions. So we've taken all of those actions from over 40 countries and built a toolkit based on those, based on the high frequency requests from countries. So at the same time that you're talking at the policy level, you need to make things that can be in the hands of people delivering care and in the hands of people who need care. Similarly, you need to count things. If you can't count things, you're not as effective. So we have a few tools that are all about counting things. This is the registry on the WHO platform. So instead of just telling people to improve quality or think about quality or to do trauma quality improvement programs, we had to build a tool so that that was actually more within reach for countries. So an online platform that is available free of cost to countries that want to do registries. Counting things lets you do a lot of other things. You can also then compare the cost, because everything costs something. You can help advocate and say, look how effective these services are relative to other ones. And then finally, and I'll stop because I know we're close to the end, I want to show you just a few quick ideas about why it's important to share a story. And that's a very intentional choice of words. So when you make big choices about how you organize services, what happens as a result of those choices, whether you intend it or not, good choices or bad choices, you make a channel of least resistance. The choices you make will create, the choices policymakers make and subnational planners will create a pathway that their population will be encouraged to follow. It's a channel of least resistance. Hopefully, these are channels that are good and serve population health needs. Sometimes you can make mistakes and these channels are bad. But either way, the choices that are made about the organization of services, they create a pathway. And the best way to see what happens within a pathway and whether it is working and suits people's needs and desires is to look at people's stories. So when I say share a story, every time you think at a high level about organizational choices that create a pathway, also think about the people who are going to go through that pathway and what is their individual journey and what is needed. And this is sometimes, for some audiences, the most effective way of communicating a bigger point. This is an 11-year-old boy at the time of the picture who was 8 when he fell out of a tree and was not able to get the simple fracture care that he needed at his local hospital. And there are a lot of consequences to that simple failure for him in his life going forward. And then I also mean, when I say share a story, put yourself in the story sometimes. This is a text I got from my mom, and I've shared this with a few of you before, after her cataract surgery. And I like this because it just shows there's a lot of different ways to look at the benefits that surgery and other kinds of services that we're talking about today, the ways they can change a life. And sometimes they're small and sometimes they're bigger. And the very last slide, really building on what several people have said, when I say share a story, I don't only mean tell a story. I chose the word share very intentionally. You should be part of that story. You're not outside the story helping someone else. And this is a quote that really, really changed the way that I think about everything I do. I luckily came across it quite early. And it took me a while to understand why the idea of help bothers me so much. And it's because there's an inherent condescension. So you shouldn't be going somewhere to fix a problem. You should be going because it's unacceptable everywhere in the world that anywhere in the world should be without these simple, really cost-effective and life-saving services. So that's what I mean by share a story for sustainability. If the story is the same story for all of us, because our liberation is bound up together, then that is a very sustainable mechanism for the kind of work that we're trying to do. Thank you very much.
Thank you very much, Terry. And for ending on a note that to some extent captures a fair amount of the themes through here, the importance of stories, of connecting with the public through stories, connecting with politicians about stories, and engaging and encouraging ourselves through stories. We're just about out of time, so I'm going to hand it back to Teresa Chin for the final words.
Thank you so much, Adrian. I really want to thank you, CUGH, for the opportunity for us to have this discussion, have this panel, allow people to engage and learn about the different concepts that exist towards expanding SOTA and how we can really strengthen some of the health systems and sustain them ultimately. I really want to thank the sponsors, all the different institutions that helped make this session possible. And I really want to thank to all the moderators and the panelists for their insight, their preparation, and their time. And moreover, I really want to thank the audience for their engagement. And, you know, I hope that this is just the start of the conversation to come, that there will be more engagement, collaboration, and more projects to come in the future.